Hi, good morning, good afternoon. Welcome to today's meetings organized by the BMJ and our journal BMJ Evidence-Based Medicine in partnership with Beijing University of Chinese Medicine. My name is Juan Franco. I'm the editor-in-chief of BMJ Evidence-Based Medicine. I'm also a clinical editor for the main BMJ, and it's a great pleasure today to chair meetings on advancing traditional and integrated medicine. We have many experts from China, UK, and Australia that will provide their expertise on the topic. And in this meeting today, we'll have three themes. Each of them consists of a keynote speech and the panel discussion covering the generation, integration, and translation of high-quality evidence in the integrated medicine area. Today's event is bilingual, Mandarin and English, wearing these devices, with simultaneous interpretation on both online and in person. So I would like to take a couple of minutes to discuss a little bit from the journal's perspective of what we've been thinking about traditional Chinese medicine and integrative medicine in the field of evidence-based medicine. As you know, evidence-based medicine is about the expertise of clinicians, the evidence, and patients' values and preferences. Those are the three circles and fundamentals for evidence-based medicine. Traditional Chinese medicine has lots of experience, in over 2,000 years of experience, and is deeply rooted in the local culture, so it's appreciated within the values and preferences of the community. So from my traveling in China, I've understood that there's a interest and efforts to grow the third part of the three circles of evidence-based medicine, which is the evidence generation, understanding what works and is within the field of traditional Chinese medicine. Having said that, there are general aspects of evidence generation and translation that by which traditional Chinese medicine may face particular challenges, not only in traditional Chinese medicine, but also throughout the spectrum of evidence generation and overall research. We are seeing changes in the way we do research, in using new methods, trying to focus on open science, patient participation, and all of these elements of the new methods, open science and patient participation in research are not exclusive to traditional medicine research, but traditional medicine research will need to get up to date with these new standards. So it's particularly important to think about these high-level issues of what's going on in the research world. Secondly, I would say that, of course, traditional Chinese medicine or traditional medicine in general face particular challenge that are inherent to the type of intervention that we're assessing. Traditional Chinese medicine and traditional medicine in general are usually complex interventions. They involve holistic care of the patient, understanding not only a symptom, but the whole patient in general, and the contextual determinants of health and the different syndromatic presentations. And also that is from the diagnostic side. And from the intervention side is also complex intervention composing by herbal medicine, acupuncture, and advice on daily lifestyle. So both the diagnostic peculiarities and the complexity of the interventions make the generation of evidence quite challenging in the sense of trying to figure out what works and what doesn't work. And when we try to combine that with the elements of how that traditional medicine could be integrated into a more integrative medicine approach that includes not only the local traditional medicine, whether it's Chinese or other types of traditional medicine, but also the typical Western medicine, that poses additional challenges. So, and I would really be interested to see what the discussion from the panel say about that. So we have different topics throughout that it was organized by the BMJ and the university, which are very exciting about the frameworks. That this relates a little bit about the frameworks of integrative medicine, and the synergistic integration, and that relates to the complexity of the interventions that I was mentioning before, where you incorporate more than one component interventions, you may expect additive effects, synergistic effects, or antagonistic effects as well, could be. And the last part, translated evidence into practice, and the role of clinical practice guidelines, which is also would like to hear from the experts, because there's a lot of interest of the local guidelines in China and how does traditional medicine may play a role in translating what we know about traditional medicine into clinical care, but also what are the expectations on and methods that you think when you exporting, let's say, traditional medicine into other countries where it's not so prevalent. So those were my first comments. I would like to introduce now other opening remarks. The first guest would be Professor Congzhi Liu, Vice President of the Beijing University of Chinese Medicine. He also serves as leading scholar of high-level Chinese medicine disciplines, appointed by the National Administration of Traditional Medicine, and has a rich experience on the evaluation of clinical efficacy and mechanism of actions of acupuncture and moxibustion. Welcome.
Thank you. I do welcome all of you to participate in today's meeting. On behalf of Beijing University of Chinese Medicine, I would like to extend my warm welcome to all of you and to all of my colleagues in BMJ led by Professor Franco. Our university is the only TCM university that is belong to the 211 program. We have 16,000 students, 2,000 staff faculty. We have 3 campuses covering an area of 1,700 mu, and we have 3 affiliated hospitals, Dongzhimen, Dongfang, and the 3rd affiliated hospital are our teaching hospitals. And then we have a great talent pool. We have 5 academicians, 16 TCM masters. In the education, clinical practice, and research of traditional Chinese medicine and international exchanges, our university plays a very important role. Like Professor Franco just mentioned, TCM and traditional medicine in general has a time-honored history with empirical experience over 2,000 years. And constituting our current system, we do value practice and experience, which is empirical. However, with the advancement of modern medicine and with the development of time, science, and technology, we do require more evidence generation and data to support our current medical care services provided to our patients. In particular, we need to generate high-quality evidence to support our practice and to facilitate the integration of conventional medicine into international guideline and expert consensus that can be more and more widely accepted by our colleagues in the international arena, so that we can raise our voice, can serve more patients, and to serve the humankind as a whole. In China, as you may already know, we have abundant medical resources. This morning, guided by China TCM Bureau, our university, together with the other universities in China, we are preparing to establish a nationwide TCM affiliated hospital alliance for discipline development, where we have 11 initiating institutions, together with their 20 or so TCM universities and colleges, together with their affiliated hospitals. We will co-establish such consortium or alliance. It demonstrates the demand coming from the patients who are willing to be treated in TCM hospitals, and we do need to provide such services based on data and evidence. We are willing to roll out RCT, cohort study, observational studies, and real-world studies. Today, we look forward to the contents of today's meeting. We will ignite new ideas to have a brainstorm together so that we can facilitate the transformation of the empirical medicine of TCM to evidence-based medicine, and to facilitate the internationalization of traditional Chinese medicine. Thank you so much again. I wish today's meeting a complete success. Thank you, Professor Franco, and your team. Thank you. That's all from me.
Thank you, Professor Liu. Now I would like to introduce Ms. Yu Yang Kong, Managing Editor of BMJ China, to express her wishes for this event on behalf of the BMJ Group. She's joining us online today.
Thank you, Juan. Can you hear us? Can you hear me okay? 在场的
Yes.
老师能听见我吗？好的，谢谢。
Okay, we can hear you very well.
北京中亚大学
Distinguished team, Vice President, President Liu, Professor Zhang, my colleagues, experts, ladies and gentlemen who are joining us online and on site, our friends from Yangtze River Medical Group. Sorry, I am on a business trip, so that I can only join you online. BMJ Group, we have 180 years of history. After a half a century development, we are a pioneer of evidence. We published the first RCT in the whole world and published evidence-based medicine journal and established a library to this end. We have 70 also journals in our group, publishing tens of thousands of papers every year. We are committed ourselves to evidence generation and to support our field. Our flagship, BMJ, and our evidence-based professional journal are leading journals and classical journals to this end. Today, we are very happy. We have editor-in-chief from both journals to participate into today's meeting. We have Professor Tang Jinling, who is an worldly renowned expert in evidence-based medicine. And also we have invited Professor Franco to be our co-chair today. TCM has a time-honored history. We need to carry down the heritage passed down by our previous predecessors. Today's theme is of a great importance, that is global convergence on evidence and integration, advancing traditional and integrated medicine with a high-quality evidence generation. We want to improve the evidence-based essence of a traditional Chinese medicine so that this empirical medicine can be more evidence-based and more practical and widely accepted by the international arena, benefiting more patients at home and abroad. In order to support today's meeting, we have invited our media friends. After that, the 21st Economic News, the Renmin Network, and other important media will broadcast today's meeting and follow up the impact after the meeting. This undoubtedly will help us broaden the audience of traditional Chinese medicine so that more stakeholders can get on board. In addition, BMJ Group, after the meeting on our official website, we will create a special column to showcase the reports and contents of today's meeting. Professor Franco, Editor-in-Chief of BMJ Evidence-Based Medicine, has told us, based on the contents we're discussing today, we will explore the further opportunities for paper publication, for the possible directions of future collaboration. I'd like to say thank you to all of the supporters for today's meeting. Thank you so much for the Beijing Traditional Chinese Medicine University. Thank you, President Liu, for your support. Thank you, Professor Liu Jianping's team. You are very helpful in inviting experts and designing the agenda. Thank you, Professor Jingling Tang, for your Very invaluable insights. Also, thank you Yangtze River Pharma for your great support so that our meeting can be very smoothly conducted. Last but not least, I do look forward for today's meeting. I do wish today's meeting a complete success, and I do wish in the near future BMJ can discuss in an in-depth manner with all of the audience participating today. See you again next time.
Thank you, Yuan. Last but not least, I would like to introduce a representative of the sponsor for this event. Chongming Gu is the head of the marketing and medical affairs of the departments of the Yangtze River Pharmaceutical Group. Thank you. Welcome.
Chief Editor Juan
Distinguished Mr. Juan Franco, Professor Ming-Su Lee, and President Liu, and Madame Kong Yuyan, experts from online and offline, and their editors, it's my great pleasure to be able to found such an event. We think this event is highly valuable. I myself is also a doctor. I have been a doctor for 15 years. Before I joined the pharmaceutical group, I used to work in Beijing Medical University in GI department. And then I joined the Johnson and Pfizer, etc. Now I am leading the Yangtze River Pharmaceutical Group, and I'm the head of marketing and the medical affairs department. After joining the Yangtze River Pharmaceutical Group, my biggest impression is in TCM, evidence-based medicine is still having the gap when we compare those to other Western pharmaceutical companies. So the first thing I'd like to think about is how we can introduce the evidence-based medicine philosophy into the field of traditional medicine. We've been talking with a lot of TCM experts, including president of hospitals and colleges. They are all very interested in doing this. So we have made a determination. We're going to support significantly our source of evidence-based medicine research in the hope of promoting this industry to develop. Today's meeting will be a commencement. I've been talking to the GM. We've been knowing each other for over a dozen years, and then we were thinking, can we start with a high-end Chinese English dialogue so that the traditional medicine, evidence-based medicine can go to the world quickly, and we can explain our products and our services more clearly to the whole world. From the Yangtze River Pharmaceutical Group perspective, we have a history of over 50 years. And in China, we're also a top-level company. We have Western medicine and the traditional Chinese medicine account for 50 and 50%. So we are very familiar and we hold great expertise in traditional Chinese medicine. Innovation protects health, and we want to inherit the greatest Chinese value. So innovation is critical. We cannot always rely on our past experience. The previous speakers have also mentioned we have to go from only empirical medicine to evidence-based medicine. And we are talking mainly about RCT, but in the future, the real-world study also plays a vital role. Our company has done the first data-based translation study in China. In cooperation with Taizhou Digital Department, we've completed our first translation project. We have recruited over 100,000 patients with chronic coughing, and we are going to expand that to even 200,000 patients and even 1 million patients. We're going to build a really large disease pool, and we hope to open it to all the experts, where you can conduct more research and publish better paper, so that we can conduct more in-depth TCM-related research. This data can not only serve clinical studies, they're also highly valuable to new drug development, because we hope By doing so, we can understand better the underlying principle of a disease, how the patients can be treated, how the patient will recover, so that we will always be patient-centered and demand-driven. I believe with the cooperation of the industry and the medical community, we're going to bring our work onto an even higher step. We are very much looking forward to the success of today's meeting. We are hoping to hear our dialogues in terms of methodology, challenges and opportunities, etc. And we are looking forward to more opportunities of cooperations in the future. And I wish today's meeting a great success. And in the future, we are going to promote more papers to be published, and we are going to maintain close relationship with our editing team, hoping we can have more in-depth collaboration. I wish today's meeting great success. Thank you very much.
Thank you, Dr. Gu. Now I will hand over the moderator role to my BMJ colleague, Professor Jingling Tang. Welcome.
Thank you. 那我还是用中文吧，这样的话就直接一点。
I think I'll speak in Chinese to make it more straightforward since we have interpreters. It's my great pleasure to see all these experts gathering here today.
这个 EBM 这个
Talking about BMJ EBM and talk about traditional Chinese medicine's future development, how we can further advance to the world. We have been discussing this topic for many years. We have made achievements, we have encountered difficulties. In the future, we hope more patients around the whole world can benefit from traditional Chinese medicine treatment. So we have to go out. But how exactly we can go out? How, with the help of our international friends and colleagues, to make our steps going forward even faster and better so that all patients throughout the world can enjoy and benefit TCM. So that's the main thing we're going to talk about today. In the first session, we're going to talk about methodologies. We will focus on clinical effect evaluation. Over all these years, what difficulties we have encountered, what new opportunities have arisen, and what breakthroughs we have made. We have invited 3 keynote speakers who are all very famous scholars, and then we will have more panelists participating in the roundtable discussion. So our first speaker is Professor Charlie Xue. Professor Xue, are you there? Professor Xue is actually a graduate from the Guangzhou University of Chinese Medicine, and then when he went to Australia, he did a huge amount of work in promoting traditional Chinese medicine. Professor Xue is an old friend of us, and we just met each other in Guangzhou a few days ago on another meeting. And he is the Associate Deputy Vice Chancellor of Royal Melbourne Institute of Technology. And in terms of TCM, he has done a huge amount of work in promoting TCM in Australia. Thank you very much for participating, and the floor is yours.
Ready?
Thank you. Can you see my slides, Professor Tan?
Oh, not yet. Okay, you need to share your slides with us.
Yeah. I think. Okay. All right.
It's okay, we can see it now.
You can see the slide now. Thanks, Professor Tang. Thank you. And thank you for the organizers for giving me this opportunity to share some of my experience in the area of working in developing the evidence base for Chinese medicine in the Australian health context. I chose the topic today, best available evidence that supports Chinese medicine clinical decision-making. And I'll be talking about the whole evidence-based approach. And the work we have been doing in Australia through a collaboration with Guangdong Provincial Hospitals has been going on for 18 years. And I see that Professor Guo Xingfeng is in the audience as well. And he's also been a very important contributor to this partnership. When we're looking into evidence-based medicine, I don't think I need to say much about it because most of the audience here would have a very good knowledge about evidence-based medicine. What's really important I want to highlight here is when you're looking into the three circles on the left-hand side and the center we call evidence-based medicine, Chinese medicine practice has always been very proud about using clinical expertise of the clinicians. And also actively engaging patients in understanding about their preferences, values, concerns, expectations, and that sort of practitioner and doctor partnership in Chinese medicine has always been a strength. The critical area is about best available research evidence. As mentioned previously, I think this currently or for a very long history is really based on experience rather than evidence. And I know that about when individuals who have experience in seeing Chinese medicine practitioners, the difficult components always about understanding the evidence and use the evidence to provide advice about the chance of clinical benefits and the safety, as well as other aspects like the duration of treatment and the likely outcomes. On this slide, I also highlight a couple of points. I think one of the very important points, the first one is about using current-based evidence in making decisions about the care of individual patients. And this is quoted directly from a paper by David Sackett, published in 1996, about making decisions about the care of individual patients, rather than a population base. The second point I would like to highlight here, the third dot point here, is practice without clinical evidence. That's really important to know that without clinical practice risks becoming paralyzed by evidence, and for even the excellent external evidence that may not be applicable and appropriate for an individual's patients, which is really important when looking into the current research, and most of the outcomes from current research, they're not really applicable to individual patients in Chinese medicine, as the theoretical framework is different, and also the clinical decision-making is quite different. Currently, when you're looking into the best available evidence, the most common model we use is the hierarchy model, which divides evidence into different levels. But in Chinese medicine, one of the challenges you're facing is as most people mentioned already, is that the highest level of evidence is commonly lacking because there are many challenges to conduct clinical trials in Chinese medicine, as well as to looking into translating the evidence into practice. Most commonly, the evidence available in Chinese medicine are lower level, including expert opinions and classical literatures. In 2006, Professor Harold Wallace and colleagues present a circular model, looking into when you use a model to evaluate clinical evidence for complex interventions like acupuncture, like herbal medicine, which is quite different from a drug therapies in terms of clinical evaluation for drug therapies. So this model, really the circular model, combine what's considered to be experimental design to more descriptive literatures to see how best we can combine all this literature together to support clinical decision making. When we look into the Chinese medicine, in the case of Chinese medicine, even the circular model will probably still missing important components like expert opinion and classical literature. So how are we going to evaluate the best available clinical evidence that can be applicable, can be translated into clinical practice? It represents a number of methodological challenges. So this summarizes the point I mentioned so far. And I think what's really important is like we need to make sure that when we're looking into generating evidence for Chinese medicine or looking into evaluate and translating the evidence into practice, we need to make sure that the evidence generation process is consistent with Chinese medicine theory and to make sure that they can be readily used to support clinical practice. So based on this understanding, over the last close to 2 decades, the Center of China-Australian Center for Chinese Medicine Research, which was funded by a grant from the National Administration of TCM, as well as a grant from the Ministry of Chinese Ministry of Science and Technology from China. And for us to develop this methodology, what we call whole evidence-based approach, is an expansion of the circular model plus looking into looking into classical literature and experts of opinion, because our understanding is modern Chinese medicine is rooted in classical literature, and that's my learning as well, and it's also the practitioner will tell you, and the legacies provided by ancient doctors and their patients. It's also grounded in the practices of expert clinicians and increasingly informed by clinical and experimental research. Considering Chinese medicine's stage of international development, which Professor Teng mentioned about it just a few minutes ago, a whole evidence approach is an appropriate method for compiling and synthesizing different types and levels of evidence for specific types of interventions. So the way we have been looking into that is bringing together expertise from experts in Chinese medicine and research from Guangdong Provincial Hospital of Chinese Medicine with RMIT, and also have many other experts' contribution, including Professor Jianping Liu and others, help us to really looking into how we're going to implement these models into the evidence evaluation and new evidence generation process. I'm not going to read through all the details about like classical literature or contemporary clinical manuals and expert consensus. And what we try to do is like I bring this together and provide an evidence monograph that can be used to support the clinical practice towards more towards evidence-based healthcare. If you want more details, you can read the paper we published in 2019 about accelerating the comprehensive and systematic evaluation of clinical evidence of Chinese medicine using a whole evidence-based approach in Global Health Journal. So based on this approach, over the last decades, we have been working together to develop 29 evidence-based Chinese medicine monographs. And that all the English version have been published by World Scientific in Singapore, and the Chinese version has been published by People's Health Publishing House, 人民卫生出版社 in China. This development also received recognition and support from the World Health Organization. And on the right-hand side, it was a report still on the website, I think it's called WHO, recognizing an approach that has been developed to address methodological gaps in traditional medicine. It's hard to read this one, but I think what we try to do to show you here is like, let's say choose like rheumatoid arthritis as an example. What we have done is looking into, in the monograph, we're looking into clinical guidelines and textbooks, bring together about the way clinical practice in Chinese medicine by syndrome differentiation and looking into the classical literature and modern literature to see whether this framework has been applied in the design of the clinical research. And also in the other interventions like herbal medicine, in herbal medicine and also in acupuncture to see how this theoretical framework has been integrated into the design of trials. And for those who have applied differentiation in the clinical trial design, we also separate them to look into how can this be better integrated into clinical practice. And through this method, we have complete 29 monographs, as I mentioned earlier, which cover 3 components. And one is really looking into the evidence generation. And you can see the picture there illustrating the relationship between the 3 components on generation, evaluation, and implementation. Tried in this doing this process to really bring together of the Chinese medicine theoretical framework with a mindset about how we're going to make sure that quality data have been generated through new trials, through evaluation, and how can this be translated into clinical practice. And as we emphasize again about the importance about bringing together rigorous methodology to ensure the relevance of the data for enhancing practice and to make sure that it strike a good balance between internal validity and external validity. We understand that when you're looking into that implementation, the number of barriers, and this is paper published by Liz in 2022 and colleagues, looking into the barriers of implementing evidence into practice for complementary medicine. It highlights 4 areas of barriers: structural, cognitive, cultural, and attitudinal, and also propose methodology to look into how can we overcome these challenges. Like, for example, improving access to database and evidence reviews, supporting skill acquisition, and that's really important for supporting like practitioner and student to develop the skills for a practice of evidence-based medicine, as well as cultivating leadership and interprofessional, inter-agency collaboration. There's also literature indicate a paper published in BMJ in 2022, which indicate even when evidence is available, they have not been adequately translated into practice. So a paper published in BMJ in 2022, examining 2,471 systematic reviews of acupuncture, which review acupuncture therapies highlights that even with the good data, they have not been adequately translated, and also propose a number of the approaches, again, about like incorporating acupuncture evidence into decision-making within health systems, building joint research production effort. I think the collaboration is really important. Digitizing and disseminating evidence on acupuncture to facilitate access to patients, clinicians, and policymakers, and prepare practitioners to have better understanding about how to use evidence. How do I go with time? And
这个教授还是快一点了。
Yes, please catch up. It's a little bit behind, 8 minutes behind the
I
agenda.
will not go into details here. Sorry, Professor Tang. I think here this is really to summarize some of the work we've done over the last 15 years. And we're talking about the next step of translation and the potential use of AI to support data update and the translation process. Some of our work has been incorporating into 11 clinical guidelines, including insomnia, sleep disorders, allergic rhinitis. But I think this is really important to see quality evidence can be incorporated, but we need to develop methodology to support translation. So the key message here, I think, is important to get quality evidence and to support translation. Make sure that the evidence generation and translation are consistent with the Chinese medicine theory and practice. Apologies for going over time, Professor Tang. Thank you. Thanks, Professor Tang.
Okay, now let's welcome the second speaker from this chapter, Professor Myung-Sung Lee, to give us a presentation. 8 minutes, sir.
Hello, my name is Myung-Sung Lee in Korea Institute of Oriental Medicine. It is a great honor to be joined this important meeting. Today, I would like to present the reporting standard, data sharing, and evidence for traditional medicine. This is my presentation content. In 2014, the Lancet published a series of research increasing value and reducing waste. The following year, University of Edinburgh hosts Reward Equator Conference to advance research transparency and quality. The primary goal of reporting guideline is to ensure clarity, completeness, and transparency, enabling leaders to assess validity, interpret finding, replicate the method, and understand what was done and was found. Among these reporting guidelines are particularly important for improving transparency and reporting quality. By 2019, as you can see on this slide, more than 400 reporting guidelines have been developed. According to the recent report by Professor Chen in Lanzhou, 26 reporting guidelines related with traditional Chinese medicine have published. Of these, 14 guidelines were registered in Equator Network. The overall compliance with the guideline development guide was 63.3%. In addition, the rate of publication in English language journal was higher than that of Chinese journal. About 15 of the guidelines have been cited more than 100 times, while nearly 3/4 was cited fewer than 15 times. The author concluded that the developer of the TCM reporting guidelines should follow more rigorous scientific process to strengthen their guidance and improve promotion, implementation, and dissemination. The evidence map is a form of evidence synthesis. The visualize show evidence gap and study characteristic, and sometimes also summarize study quality across the multiple studies. We developed the evidence map for traditional medicine funded by WHO, as you shown in left side. The final map was available in WHO website, providing information on 2,719 systematic reviews in traditional medicine. Systematic review on traditional medicine steadily increased from 2018 to 2021, and stabilized in 2022, China produced the vast majority and followed by South Korea. Herbal medicine with the red circle and acupuncture with the blue circle are the most widely used traditional medicine intervention across all ages. Their broad application for various adult health conditions reflected in scattered ICD-11 classification indicate a consistent, age-independent approach to traditional medicine. A critical issue with included systematic review is their overall low certainty of evidence. 93.9% were classified as critical low, only 0.9% is high, and 1.1% is moderate, highlighting a widespread methodological quality issue. Traditional medicine research is limited by overemphasis on herbal medicine and acupuncture, insufficient pediatric study, poor systematic review quality, and concentrated geographical distribution. Data sharing is defined as a set of practice, technology, cultural element, and legal framework that make research data available to other investigators. And data sharing is vital to traditional medicine, strengthening credibility, collaboration, ethics, and global health impact. Challenges include poor standardization, cultural IP concern, and technical barrier. Overcoming this barrier require standardized data protocol, clear ethical guidelines, strong infrastructure, community engagement, a culture of openness, collaborative platform. A paper published in this week examined data sharing in acupuncture meta-analysis, focusing on its association with journal policy and practical consideration. Articles in journal with data sharing policy were more likely to include data availability statement. These statements appear more open when sharing was mandatory rather than only recommended. Non-chem journal outperformed chem journal in including data availability statement, although actual data availability was similar. Impact factor of journal show no significant association with data sharing practice. This is my last slide. Enhancing the credibility of traditional medicine research require better reporting, trial and review registration, rigorous study design, and active patient involvement. Incorporating real-world data will further strengthen evidence and ensure its trustworthiness. Thank you very much.
Thank you very much, Professor. You just used 6 minutes, but that included a lot of content. Then let's move to the...
from 北京中医药大学吧。那好 ，ready 你就可以我这介绍在这上面大家看一下。
You can start anytime you're ready. And the introduction of Professor Fei is on the screen. When I first knew Professor Fei, she was still very young, and now she's got all these titles.
Dear all, thank you very much for giving this opportunity for me to present methodological challenges and possible solutions for Chinese herbal medicine clinical trials. Here are my 3 topics. First, the current research status for CHM clinical trials. This is from Chinese journal databases. You can see until the year 2015, publications increased, and afterwards it slightly declined but stayed stable. On the peak, it's nearly 500 trials per year. In the Web of Science, we can see it is increasing gradually and fluctuated at a high level after the year 2020, and the peak is 400. So the English publications are becoming more and more. Here are some representative publications of CHM clinical trials in high impact factor international journals. As we all know, the practice of traditional Chinese medicine based on holistic view and greatly depending on syndrome differentiation and treatment, and using integration of the 4 diagnostic methods: the inspection, listening, smelling inquiry, and palpation. And we are modernizing. So that such kind of characteristics in clinical practice will bring challenges, very specific challenges. The first one is in the new drug development. For CHM new drugs, some of them or many of them are compound drugs. So the main ingredient, herbs, they are long time used in clinical practice, but adjusted personally in practice, guided by TCM principles. So this will bring challenges. The real world evidence of the practice existed, which could serve as supporting evidence for new drug development. But it is challenging to recognize the specific compounds when prescribed as a group of herbs. And the continued release of the relevant policies and guidance development documents has encouraged the use of the real-world data in the development of new drugs. The second challenge is the new compound drugs, the indication on the drug label are very challenging. For example, in the label, the indications of the drugs, the current status is 35%. They present both Western medicine and TCM disease names, TCM syndrome and symptoms for the prescription drugs. And another 35% use only Western medicine disease without TCM disease names. As to the OTC, that is a different picture. 49% of the TCM syndrome and TCM symptoms are labeled no Western medicine disease names at all. So that brings us the challenge is how to match perfectly when we design the trials, the eligibility criteria to match the current status and clinical use. Here are pictures to show the color changes of the Chinese herbal medicines with the temperature, the room temperature, and the wetness in the room. So the placebo development for CHM are really very challenging. As there is another type of study is the investigator-initiated trials called IIT. We face different challenges in this type of studies. The first one is evaluating effectiveness of CHM treatment principles, or people would like to invest effectiveness of main compound with personalized adjustment. For the first one, people allowing TCM principle-guided flexible prescription. And this will lead to the challenge of the scientific demonstration of good practice. That is challenging to provide very detailed and clear guidance for the application of the principles. And when we evaluate the effectiveness of main compound with personalized adjustment, we face how to make sure the personalized add-on or take out herbs do not substantially change the essential of the tested main compounds. And the second one is the control of risks and biases for pragmatic trials. When people choosing the control group interventions, the risk of inappropriate chosen, no blinding, information biases, and quality control difficulties when we are facing a lot of variabilities. Here are some possible solutions we can think of. The first one is we could think of the level of the trial design in three levels. The first one is to clarify the research purposes and determine the most suitable RCT type specifically. After this, we will have to face the comprehensiveness and completeness of the trial parameters, including clinical parameters and also methodological parameters. The third one is, after that, the harmonization among all those parameters. You can see this picture. This is a tool called Precise Tool. It showed us 9 domains illustrating the pragmatic level of a trial. In the left two pictures, they are round. No matter big or small, they are round. This is good. That means harmonization. And the other one on the right corner, it is no longer to be called a circle. So that means unharmonization of trial parameters. When this exists, it will reduce the effect sizes of the clinical trials. This we have to be aware. And another thing we have to be aware and try to control is the fragility of the possible results of the CHM trials. You can see the total sample size, number of events, TCM syndrome differentiation, and the risk of bias are important factors to increase the fragility of the positive results of the trial. We have to control that. So after all kinds of investigation, we developed a checklist for CHM trial design to control failure risks. In this long checklist, we include all the steps of developing clinical trials for CHM. And based on that, we endorsed the FEMA model, that is the failure mode and effect analysis model. And we have put high priority, medium priority, and low priority for action to improve the quality of the design to avoid failure risks. People in our field, researchers, they've developed a standard for evaluation of placebo simulation effect of Chinese patent medicine too, along with several relevant national standards for sensory inspections. We believe the control and quality evaluation of CHM placebos could be conducted better and better. That's all. Thank you very much.
谢谢3位教授的演讲。
Thank you. I would like to conclude or summarize their main opinions in a few words. Then we are going to proceed to the roundtable discussion. I can start from Professor Lee's speech. He said there is a reporting standard internationally. So that means there is an internationally recognized methodology or system to evaluate. Since we have got a standard, that is a mutually recognized thing, saying that doing so is correct. That is the right thing to do when evaluating TCM. Now that we have the standard, we still have a lot of problems and issues. So how do we deal with this? The three speakers have given your solutions and opinions. So whether we use RCT or other methodologies to evaluate TCM, there are still a lot of challenges because there are a lot of things that we cannot evaluate. So that brings us back to Professor Xue's opinion, what is beyond RCT? On the one hand, we have been evaluating TCM efficacy, and that is actually verifying and validating the theory of TCM. Because if the theory is not validated, then its clinical practice must have a problem, and vice versa. This process may take very long. So we need to do so many work with TCM. Actually, so far we don't have, strictly speaking, TCM RCT evaluation. So our previous so-called experience is still our clinical experience and observational studies. Maybe we can have more detailed categories. We have better observations and worse observations. We mainly count on our personal experience. What we read from the textbooks are basically collections of empirical experiences.
So how can we use this existing experience to advocate and promote development of TCM? We have heard the valuable opinions from our previous three speakers. And next, we will invite a few more panelists who are very well known in this area. They are Vice President Mr. Liu Cunzhi from Beijing University of Chinese Medicine and President Shang Hongcai from Dongfang Hospital, Beijing University of Chinese Medicine, and Mr. Guo Xingfeng, Deputy Director of Clinical Research Center, Guangdong Provincial Hospital of Traditional Chinese Medicine. Among the three of you, how many of you are online now? Okay, I see you now.
I see Professor Guo. Where is Professor Shang? Oh, you are representing Professor Shang. Okay, now the floor is yours, our panelist. President Liu, could you be the first one? Okay, I'm here to learn. Listening to Professor Xue and the first three keynote speakers' presentation, Professor Xue's presentation has illustrated in terms of evidence generation, evidence evaluation, and translation. It is a very important concept. How can we integrate classical literature, modern literature, and how can we integrate other sources of data, including clinical observation, which have a different level of evidence? To my understanding, the most important thing is how can we translate the evidence to clinical practice. While providing evidence, very often, especially I will take acupuncture as an example because that's my focus of area. Some protocols are not widely used in clinical practice. We are doing studies for the sake of clinical trial, simplify the acupuncture clinical practice, make it standardized. After data generation, how can this simplified practice translate into the complex clinical practice? I think in the near future, for the protocols and the study design, we need to make them more related to clinical practice, because TCM are based on a classical textbook and based on our Asian physician experience, right? So in terms of clinical trial design, we need to make it optimized, more related to clinical practice. In translation from evidence to practice, how can we integrate this evidence to clinical guidelines, international ones, of course, to make it more acceptable? A couple of years ago, we have conducted an acupuncture study on knee OA, or osteoarthritis. Together with the Australian team, they have published their paper on a very distinguished journal, a debate of using acupuncture on knee OA. We have conducted 4 studies. It has been integrated with the NICE guideline in UK. And later, and of course, we have also carried out some clinical trial focusing on functional gastrointestinal diseases, which are recommended by Japanese guideline. So I do believe with our efforts, we can make our evidence being integrated in international guidelines. Another thing I like to make is that we need to carry out more international collaborations, including a lot of countries and centers in the whole world, and we need to include more population so we can have a wide variety of genetic profile. These warrant the needs of international studies and collaborations. In addition, I've listened to the third and the second and the third speaker. Thank you so much, Professor Li and Professor Fei. You have talked about how to roll out the guideline, the processes of rolling out such documents, and some challenges for TCM in carrying out clinical trials and other studies. I think one of the features of conventional or traditional medicine is we need to learn from the rigorous methodology of modern medicine. On top of this, we need to establish methodology which included the traditional Chinese medicine characteristics. Led by Professor Liu, their institute has made a lot of innovation on methodology. How can we classify our classics of traditional medicine, etc.? And also in designing RCT trials, how can we establish a rigorous methodology that also include and integrates the traditional Chinese medicine characteristics? We have our own requirements. Acupuncture, we have our own features as well, because it has a larger placebo effect. It is not non-invasive. If we give acupuncture repeatedly, there will be zooming in or larger placebo effect. While evaluating acupuncture for its efficacy and safety, we do need to design appropriate methodology like the sham needle. Professor Li and Professor Yan's team, we have done a great job in different studies using a sham needle as the control arm. A reporting guideline has been rolled out. Before conducting such studies, we need to know about this reporting system. We need to learn item by item so that the trial design can be more rigorous. This is what I mean by combining the traditional medicine characteristic with the rigorous methodology. Thirdly, we need to roll out the standards and the guidelines. Unlike in modern medicine, clinicians in clinical practice, they will go with the guideline recommendation from first line, second line to third line, especially oncology. They have a very standardized like a chemo, TKI, or IO therapy. But in traditional Chinese medicine, we have already rolled out and formulated a lot of guidelines. The issue lies in implementation. We have different schools of traditional Chinese medicine. It's very hard for us to make it all standardized. There's no one size fits all. And we do value personalized treatment as well. So even if we have a lot of standards and guidelines, it cannot be generalized too much. We need to integrate general principles and with a personalized regimen. In terms of a methodology and also in the acupoint of acupuncture, it is some parts are easier than other parts. But traditional Chinese medicine and traditional medicine, as in general, we have a lot of components to be covered, which is very complicated. Last but not least, from the perspective of a cohort study and a real-world study, maybe we can use big data to help us find the responder and non-responder of a traditional Chinese medicine so that we can have a better patient selection. Maybe one traditional Chinese medicine is more suitable for this patient population, but not for the others. I think in the era of big data and AI, if we can build a very good model and algorithm to help us classify different population characteristics, we can make it more personalized to provide this regimen to our patients. We do need to combine artificial intelligence and algorithm building to establish standardized data library and the data warehouse so that we can just dig deeper into the pattern of TCM. That's all from me. Thank you. This is my bread for thought. Thank you, President Liu. Professor Shang and Professor Guo, could you discuss relating to the question, how can we do a better job with international collaboration? Professor Shang? Okay. Distinguished guest, my name is Zhang Xiaoyu. Please ask her to take the microphone, otherwise we find it difficult to hear her. So, we have conducted a lot of work in generating evidence, including from registration to design to implementation to reporting and evidence recommendation. We have rolled out related standards and guidelines in doing so. However, currently speaking, in the real world practice, there's a huge gap from evidence to practice. What type of high quality evidence do we need? First, in terms of a research question, we need to clarify it because a lot of researchers in the design stage, the research question is not clear. What are our features and advantages of traditional Chinese medicine? What is the best timing for intervention? What population shall we choose? What is the standardized regimen shall we use? We give a regimen based on experience, right? But how can we standardize such experience? This is an unaddressed question. Secondly, how can we make it standardized? Because a lot of syndromes are subjective rather than objective. How can we make them more complete, implemented, and more repeatable? We use some devices to collect the data on objective parameters, which can be translated to data so that the syndromes and symptoms can be illustrated in a more objective way. This will help us in designing and implementing the studies to make it more standardized and repeatable. Thirdly, in terms of innovative methodology, our speakers have already mentioned about the barriers and the challenges we're facing. We are having dynamic treatment in a personalized way in most cases. This is rather like how can we better match best patients to best treatment? This is another unaddressed question. We try to introduce a master pilot and other methodology. However, in the implementation stage, it's very difficult to address the complexity issue in traditional Chinese medicine. That is to say, while facing a lot of complicated problems we're having in traditional medicine, we do need to rely on real-world data using artificial intelligence, algorithm, causal relationship AI, and emulation trial. It can help us to translate evidence into practice. That's all from me. Thank you for listening. Thank you. So, let's welcome Professor Guo. You're joining us online, right? Let's hear from you. Thank you, Professor Tang, for a kind introduction. Thank you, my friends from BMJ, and thank you for your kind invitation. I regret to not being there with you in the city of Beijing. In this field, I have working in this field for 20 years. At this opportunity, I would like to briefly introduce to you some of my thoughts. First, I would like to echo Professor Xue. So he has introduced a collaboration with his team and our team. And since 2008, we started our collaboration. Professor Charlie Xue gave us his idea in the very beginning of our collaboration back in 2008. In the last 2 decades or so, we have researched on 29 diseases that TCM has advantages in. We integrated classical literature, modern literature, and we published 29 monographs, as Professor Charlie mentioned. The English version has been recognized by WHO on their website. 2 weeks ago, actually, Professor Xue, Professor Tang, in the city of Guangzhou, we have carried out another AB meeting discussing the next steps of our institution. I would like to briefly introduce to you. In the first stage, based on evidence evaluation, we have three directions moving forward. First, AI and other technology need to be used in evidence generation, assessment, and transformation. We need to conduct highly efficient and effective evidence generation. Second, we need to generate international clinical trials to generate more evidence. We have invited international experts, including Professor Tang, to establish a TCM priority selection criteria. What are the key disease areas we're going to focus on next, which are easy to generate high-quality evidence? We will choose this area to carry out trials.
So in some areas, we have got rather good evidences, as Professor Xue mentioned. A model published in 2020 on current status of acupuncture studies and applications. That includes very complete data. So we need something to present and use the existing and the valuable TCM data. That's the third direction we're going forward. And there are two things I want to add here. One is high quality TCM clinical trials and evidence, how we can generate that, because evidence serves as the core of TCM. The theory and the treatment methods of TCM is very special. It's different than the Western medicine, where we have targets, we have new compounds development. TCM adopts a different model. So in modern clinical trials, TCM does have a disadvantage. If we use RCT to evaluate TCM treatments, we do see some flaws. A simple example, the Tai Chi. We know that the most influential study was a paper reporting the effectiveness using the Tai Chi Chuan treating Alzheimer's disease and Parkinson's disease. However, is Tai Chi Chuan invented to treat these diseases? Tai Chi Chuan was first invented as a martial art and then for increasing the body's overall well-being. It's not for treating these type 2 diseases. So, if we use Tai Chi Chuan to treat the nerve pain and Parkinson's disease, how rational it is. Can it really treat the pain, the nerve pain? Maybe they can, to some extent, deal with the other complications, the other comorbidities of the patients, and their yin and yang imbalance. Maybe it can do that. But in the current RCT evaluation mechanism, we can only look at one thing. We cannot look at all these new factors. And there is also another clinical trial using the 8 trigrams boxing 8段锦 to treat obesity. The primary outcome is indicators related to weight loss, such as BMI and the reduction in the abdominal circumferences. We do see a little bit of change in the patient's waistline, but not so much in the BMI. It's not significant. But for the other parameters not within the indicators, like fatigue, some TCM symptoms like anxiety and sleep, we also see improvements in all these 5 parameters. I mean, if we only use one primary outcome, it cannot holistically or fully reflect the effectiveness and the characteristics of this 8 trigram, boxing, 八段锦, or many other TCM approaches. So I think we need to design a new types of clinical trials to evaluate the TCM effectiveness. And this effectiveness is reflected on multiple dimensions, not only one single dimension. And one final thing to add, based on previous speakers' opinion, including Mr. Gu from Yangtze River Pharmaceutical Group, they all talked about data sharing, and I have some thoughts on that. There are not a lot of people in the TCM area who's working on methodology, so we do need to form a synergy. Mr. Gu said they have been working on a translational platform. They want to purchase a database including over 100,000 cases and then make it open. I think this idea is perfect. Like now we are working on this a few dozen TCM superior diseases, and we have got this database including both Asian literature and some modern literature. I know some other experts are also working on similar database. I think we should do it better from data sharing perspective. Like we can have some discussions together and then form some sort of exchange of standards or some data sets, and then we can share this data set and share the variables, share the retrievable fields, so we don't need to do repeated work. And then if we can go from there and collaborate with the National Health Commission, if all the data can be registered there and some of the data can be shared, that will be better. I know it's difficult, but I just come up with a small idea. Maybe Mr. Gu can help establish a fund. If you agree to have data sharing, we can give you a small fund as an encouragement and a reward, maybe 20,000, 30,000 RMB, which you can use in your studies. Maybe this can at least get us started. In data sharing and putting up synergy, if we can make the first step successful, that would be a very important thing for improving all the methodology in TCM studies and forming more innovations. Now, in this session, our 3 panelists have given their thoughts and insights on our topic, and I want to speak a few more words. I personally think in my early years of career, I was very interested in TCM and I've done some tiny work. But I think one important question is, why do you want to evaluate it? Who are you try to convince? If we are talking to TCM experts, we don't need to convince the other people because we just believe in TCM. So we don't need to evaluate them. And, you cannot evaluate all the TCM things within such a short period of time, not even in 20 years, 30 years. So we have to select some important areas. We have to convince and persuade some people who needs you to do this. So we have to select. What are you going to evaluate? How are you going to evaluate? How can you convince these people? I think these are the questions we should think about when we are forming the evaluation framework. There are people we have to convince. We don't need to convince the TCM experts. We don't need to convince the general Chinese public. So we have to think about this. Who are we convincing? Why are we convincing them? And another thing is we cannot evaluate every TCM. So we have to select. And these areas we have selected will be playing a leading role. And also the basic work is also important. If we can explain the basic principle of those basic things like acupuncture, It's also a good thing for other TCM areas. Like previously, we made some investigations to prove the effectiveness of acupuncture, and then we went on to validate the effectiveness of acupuncture clinically. You know, acupuncture is the most widely used TCM technology in the whole world. And another thing is, if we want to promote TCM to the whole world, on the one hand, we are studying the principle. On the other hand, we are studying the clinical effectiveness, and we are establishing good role models. If we can publish these good models on JAMA, on BMJ, that would be very good. And another thing is beyond science, beyond evaluation, beyond trials. Are there any other forces that can help us promote the development of TCM? There must be. It's not as simple as doing the evaluation and everything's down. You know, previously when there was no evaluation at all, we just simply believed in TCM. So I think beyond science and evaluation, there must be some other forces that can truly help us promote TCM to the whole world, so that more patients can benefit from this. I know this is not something we can complete overnight. It's not something we can finish with a round of discussions. We are all interested in this, and we have done a huge amount of work on this. I know this is going to be an ongoing discussion, and I know BMJ is going to make promotion and advocate of this. When I was in the UK, that was in late 1980s and the early 90s, the whole world had a high interest in and was very passionate about TCM in traditional medicine. In recent years, although we are still discussing, I do not see such high I do not see it as popular as what I saw in the last century. I think it's not just about scientific research. So, how can we say this drug has to be a single compound, single item instead of a compound? How do we decide whether it is compound or not? It's because the Western medicine has to be a single a monomer, because it's easier to control, it's easier to judge its effectiveness. So anyway, I really appreciate the input and insights from our panelists and our speakers. As a research editor of BMG, I really appreciate your support. I will conclude my session now. Thank you all very much again. Before we jump into the next session, let's all take a group photo. Please, let's all look at the screen and look at our photographer. Thank you. Okay, President Zhang, the floor is yours. Thank you very much, and Dr. Jason from BMJ and the dear peer experts. We're very happy to bring you to the next session. I agree very much with Professor Tang's input. The first question is, are we using it as a tool, or are we seeing it as a great value? So our next theme is beyond addictive effects, innovating synergistic in the integration mechanisms of TCM medicine. So where should we put the synergy in, and what are we solving with synergy? We have 3 speakers. The first is Professor Merlin Wilcox from the University of Southampton. Welcome. Professor Merlin, can you hear us?
Yes, thank you. Good morning. Thank you very much for your kind invitation. I'm just going to share my screen. Just one moment. Yes, can you see my screen now? Are you able to see my screen? Are you able to see my screen?
Yes, we can see your slides.
Great. Thank you. Thank you very much indeed for your very kind invitation to speak at this very important meeting and for the very interesting discussions. So I'm going to speak about challenges to integrating TCM into UK clinical guidelines. So my background is I'm a UK GP and a research fellow at the University of Southampton. I've been collaborating with Beijing University of Chinese Medicine for almost 10 years now. So here's a quick plan of what I'm going to cover. First of all, the public health need for integration, focusing on the challenge of antibiotic resistance, which has been the focus of much of our research. And then I'm going to talk about 3 challenges into integrating TCM into UK guidelines: the need for UK EU GMP, the challenge of standardized or individualized treatments, which has already been addressed by some of the speakers, and then talking about evidence-based or prejudice-based medicine, and then a discussion about what is the way forward. So in terms of the public health need for integration, I think most of us are aware of the challenge of antibiotic resistance, which is predicted to cause 10 million deaths by the year 2050, 10 million deaths per year, which is more than cancer or diabetes. We know that antibiotic use is very high globally, and yet many guidelines already recommend against use of antibiotics for common infections like upper respiratory tract infections and diarrhea. Yet those guidelines are often not followed. There is an important opportunity. Training on guidelines can reduce antibiotic use. For example, there was a study in China showing that prescribing antibiotics for URTIs in children reduced from 82% to 40% in one randomized controlled trial. The GRACE intro study in Europe showed a reduction with a relative risk reduction 0.69 for antibiotics for lower respiratory infections in Europe after training people on consultation skills. But symptom control was a bit worse by not prescribing antibiotics. So the recommendation was more research on improved symptom control. And this is where herbal medicines, and in particular traditional Chinese medicine, can really have an important impact. We, together with Professor Jianping Liu and colleagues in Beijing University, have done over 10 systematic reviews now on different traditional Chinese medicines showing improved symptom control from herbal medicines for respiratory and other infections. And these systematic reviews have shown that many patent traditional Chinese medicines can improve, for example, the resolution of acute cough. And here are a few examples. So Andrographis paniculata, a systematic review, showed that in 33 trials with over 7,000 patients, the mean severity of cough was reduced. The time to resolution was reduced by 3.5 days compared to usual care, and the time to symptom resolution with usual care was also reduced by 1.2 days. Here's another systematic review of Shufeng which is a compound mixture of 8 different herbal medicines, showing a reduction in symptoms of acute cough for Shufeng plus conventional drug versus conventional drugs only, both in adults and in children. And we've also done a review of Shufeng for acute exacerbations of COPD. There were 13 RCTs comparing SFJD in combination with usual care to usual care alone. Unfortunately, all the trials were at high risk of bias, which is a problem that others have highlighted. But nevertheless, there's a signal of an important effect showing a reduction in treatment failure from 20% down to 8% for those using Shufengjidu, and a reduction in duration of hospital stay. So building on this, we did a feasibility study of using Shufengjidu in the UK for acute exacerbations of COPD. It's only a very small study, so this is not statistically significant, but nevertheless, there's a signal of effectiveness. You can see these are symptom scores here on the y-axis, and in the red bars, those taking the active Shufengjidu treatment had a faster resolution than those taking the placebo, which is the blue lines. We also did a nested qualitative study of this, looking at patients' views on Chinese medicine, and by and large, they were positive. People said, I'm aware of the worth of some of the traditional Chinese practices. As long as no animals were harmed in the making this herbal medicine, I'll be fine. If it was instead of antibiotics, I'd certainly be willing to try it, because only by trying it will you know if it's going to have any impact on you. There were a few negative views. People were particularly worried about ethics, especially animal experimentation, and use of animal ingredients. So I think information for patients needs to make it clear that the herbal medicines do not contain rhino horns and tiger claws and that sort of thing. So in conclusion, the patients and staff were generally open or keen for herbal alternatives to antibiotics. The main challenges to recruitment were COVID. This was done during COVID. But most of these challenges could be overcome. So it should be possible to conduct a full-scale RCT. But the challenge is there's no UK or EU GMP preparation, and that is a regulatory requirement. So this is the first challenge for many of these traditional Chinese medicines, Andrographis, Shufengjidu, and many others. There is no preparation with UK or EU GMP currently on the market, which means that we cannot do a full-scale RCT. So moving on to the second challenge, we've been talking about standardized or individualized treatment. I want to talk a bit about a randomized trial, a feasibility trial that one of my colleagues did on the role of traditional Chinese herbal medicine and treatment of recurrent urinary tract infections. The objectives were looking at feasibility of delivering Chinese herbal medicine in UK primary care, its safety, and exploring estimates of effect size on reducing frequency and severity of infection and impact on antibiotic use. So there were two groups. One was given standardized active herbs versus a standardized placebo delivered by a UK GP. And then in another group, they compared individualized active herbs versus an individualized placebo administered by practitioners of Chinese herbal medicine in the UK, aiming to explore not only differences between active and placebo herbs, but also differences between standardized and individualized herbs, and comparing the contextual effects of Chinese herbal medicine delivered via a UK GP versus a Chinese herbal practitioner. So here's an example of this is the standardized formula that was used. There was an acute formula for treatment of acute urinary tract infections and a preventive formula for preventing the recurrent infections. And then the individualized formula, this is an example. I think practitioners were given a list of herbs from which to choose. There were 31 women recruited into each group. The standardized arm was recruited via doctors, but recruitment was quite slow. Possibly there was not such a huge enthusiasm for GPs to recruit to this, and about half of the patients withdrew or were lost to follow-up. In comparison, the individualized arms, patients self-referred, fewer of them withdrew, 30% roughly, or lost to follow-up. There was a technical issue due to the misunderstanding of the herbal pharmacy that added active herbs to the placebo mix, but that is a problem that should be fixable in future research. In any case, there was an interesting finding in that in the standardized group, there was not a big difference between active and placebo in terms of improvement in symptoms. In the individualized group, there was a big difference between the active and the placebo. The individualized seemed to be much more effective. Similarly, in reduction of antibiotics, it was much higher. The difference was much greater in the individualized group between the active and placebo. rather than in the standardized. So this seems to suggest that it's easier to recruit and retain patients on individualized Chinese medicine. Recruitment via standard UK health centers was challenging, but it is possible to do a clinical trial of an investigational medicinal product following the regulations on Chinese herbal medicine in the UK. And it does suggest a positive reduction in symptoms and decrease in antibiotic use. But now, what is the way forward? The logical next step would be a full-scale randomized trial of individualized TCM for patients with recurrent UTIs. But the problem is, how generalizable are these results? As others have mentioned, different Chinese practitioners practice in different ways. How do we know that if we took a whole group of traditional Chinese practitioners, they would all practice in a similar way? And the other big challenge, even if we found this to be effective, how could we implement this within our National Health Service? Because we probably don't have enough Chinese practitioners in the UK to deliver this individualized treatment, unless we are very selective about which patients. So very quickly, the third challenge I wanted to mention was about evidence-based or prejudice-based medicine. And for this, I'm just going to take an example, not of a Chinese medicine, but a European herbal medicine called St. John's wort, which is very commonly used for depression. GMP preparations are available on the market. There was a Cochrane review in 2008 of 29 RCTs in major depression with over 5,000 patients, showing that side effects were less. Fewer patients discontinue St. John's wort than standard treatment due to adverse effects. It's more effective than placebo with an odds ratio of 2.7, highly statistically significant. It's as effective, no statistically significant difference between St. John's wort and standard treatment, whether that's the older antidepressants, tricyclics, or the newer SSRIs. And yet, what do the NICE guidelines say? These are the UK clinical guidelines. Although there's evidence that St. John's wort may be of benefit in less severe depressions, healthcare professionals should advise people with depression of different potencies of preparations available and should not prescribe or advise its use by people with depression because of uncertainty about appropriate doses, persistence of effect, variation in nature of preparations, and potential serious interactions. So here is an example of a herbal medicine, a UK herbal medicine. So it doesn't have the prejudices about Chinese medicine, with strong evidence of safety and efficacy, and our guidelines specifically recommend that we should not prescribe it. To me, this is an example of prejudice-based medicine. The main reasons they give are risk of interactions. Well, that happens with any medicine, right? And that's our job as doctors to be aware of interactions and prescribe appropriately. Variability in preparations, that would occur for any medicine, and that can be solved through regulation. These are not good reasons for not recommending this product. I attended a talk a few years ago by an eminent psychiatrist that had done a network meta-analysis of antidepressants. And at the end of the talk, I asked them, why was St. John's wort not included? And their answer was, it came out best, but we couldn't publish that. We couldn't admit that a herbal medicine was better than our standard antidepressants. So to me, this is prejudice-based medicine, not evidence-based medicine. So what is the way forward? How do we get support for high-quality clinical trials of traditional Chinese medicine? Evidence alone may not be enough to achieve integration in guidelines. How do we overcome the intrinsic prejudice in both patients and clinicians, especially in the UK, in favor of antibiotics, in favor of modern medicine, and against traditional Chinese medicine and herbal medicine in general? And of course, there's the problem of how we get people to follow guidelines. I'm sorry I've run over slightly, but I hope that gives us some food for thought and discussion. Thank you very much.
好，非常感谢。
Thank you so much. Thank you so much for your wonderful presentation. You raised a very important question, Professor Wilcox. The real value of traditional Chinese medicine. You also mentioned infectious diseases in particular. In the G20 hosted in Hangzhou, we proposed 5 common challenges including the Brexit. The number 5 challenge is traditional medicine. It's a very important topic. Thank you, Professor Wilcox. And you mentioned 3 challenges and 2 highlights. First, for herbal medicine and other conventional medicine, how can we make them more available, accessible? Are they in line with local regulatory bodies? Besides efficacy and effectiveness, other countries emphasize on DDI, drug-drug interactions, and side effects. Yangtze River pharma representatives are here. In order to make the drugs available and accessible, there are certain pathways. But there are challenges you may face in doing so. Professor Wilcox has mentioned a lot of challenges that is worth exploring, including the antibiotics resistance. And I do look forward to discuss with you in the in-depth manner after other speakers' presentation. Now let's welcome the next speaker. The speaker is Professor Nicola Robinson, Emeritus Professor of Traditional Chinese Medicine and Integrated Health at London, South Bank University. Over to you, Professor Robinson.
Hello, can you hear me okay?
Okay.
Okay, right. So I need to try and share my screen with you. Okay, can you see that?
Okay, I can see that.
Okay, all right then. Okay, thank you very much for inviting me to this really interesting roundtable. My topic's slightly different. It's about treating the person and not the disease and what evidence should we consider. Now, we know that traditional Chinese medicine differs from Western medicine, but in fact, in China, it's used alongside conventional medical practices. It treats the whole person, alleviating symptoms using an individualized and holistic approach. But the clinical trial publications on TCM are variable, as we know. They're heterogeneous, probably because of the RCT design. But there is the anecdotal evidence of TCM effectiveness. So perhaps we need to be looking at scientific methods to measure holistic outcomes. And if we actually try to optimize conventional research techniques and the methodologies for traditional medicine research, this can facilitate the best of both paradigms and develop high-quality patient care. I want to look particularly at stroke as a and acupuncture as a post-stroke treatment. And the reason for this is because stroke is a worldwide problem, major cause of mortality, disability. It affects patients as well as carers, and it has a range of symptoms with varying degrees of disability. So these are some of the types of symptoms, both mental and physical, that stroke patients may suffer from post-stroke. So is there a role for acupuncture? Now, some of the symptoms experienced by stroke survivors are also experienced by individuals who've not had a stroke. But we know that there is good evidence on the use of acupuncture for treating some of the symptoms.
Excuse me, Dr. Nicola, please show the full screen.
Sorry?
Hi, Professor Robinson. I'm afraid you need to reshare your screen because we can now we can only see the first page of your slides.
Okay, all right then.
Please stop sharing.
Stop share. Okay.
And then find the Zoom window and share the screen again and choose the full screen slides window.
No. No, I'm on the full screen. Yeah. Can you see that?
Yeah, and the slides are not being full screened at this state. So you should choose another slide window because when you share the screen, there should be 2 windows for the slides, and please choose the other one.
Okay, does that work better or not? No.
No,
Nicholas,
sorry.
just go to the presentation mode.
Okay. Okay, let's see. Hello?
We can't see a screen now.
Can't see it all now. Okay. Let me link in again then.
Okay. Or should I share your slides for you? I can do that, I think.
Okay, I can't get it to work, I'm afraid. Yeah. Do you mind doing that? Thank you.
So, can you see your slides now? Okay, yeah, you should see it now.
Okay, so if you can go to the next one for me.
Yes. Oops.
Why? Something very strange going on here. Okay. Okay, go to the...
I see. Where's my... Oh. Oh. Okay. Oh, so let's do it from outside. Okay, it's a bit lag. Okay. Just now you share your slides successfully, but meanwhile we also share your slides, so the Windows seems a bit strange. So can you share your slides from your side?
Okay, right, I'll try that again then. Okay. Okay, does that work?
Yeah, I think we can go this way if that's okay for you. Sorry for the trouble.
Okay, all right then. So I'll start with the second one. Where should I start? Why stroke, perhaps? I'm not able to actually. Yeah, okay. Are you changing them for me, by the way, or not? Hello.
Yes, we can, and you can
you
just
are.
yeah.
Oh, okay, because otherwise I'll change them here. Okay, so as I mentioned, the difference. If you can go to the next slide, please. Yeah.
Is it the slide you want, or
No, it's the next one. Well, okay, do a roll for acupuncture then. Okay, so there are a range of symptoms, both mental and physical, in terms of what are experienced by patients who have had a stroke. But the role for acupuncture varies really, because some of the symptoms that are experienced by a stroke survivor are also experienced by people who do not have a stroke. So there is also some good evidence on the use of acupuncture for specific symptoms. Providing acupuncture for those who have experienced a stroke addresses several symptoms at the same time, with the potential to improve the quality of life. So the evidence for acupuncture is that perhaps there is a role for the use of acupuncture in stroke rehabilitation for a variety of symptoms like dysphagia and neurological function. But again, the evidence is patchy due to small studies and poor reporting quality. Okay, I'm on to the next one. I'm on to 8 actually now. Okay, next slide, please. Therefore, it is not surprising that given the lack of RCT evidence for acupuncture as a potential treatment option, acupuncture is not currently used in clinical guidance in practice. And if there is evidence, the same evidence is not used internationally in decision-making in clinical guidelines. So the next slide shows us an article where we looked at clinical guidance in terms of CPGs and treatment guidance. If I can have the next slide, please. And out of 48 CPGs and 28 treatment guidelines, we found that there was mentions of acupuncture in 33 of these CPGs, with about 35 positive recommendations on the use of acupuncture. If we can have the next slide, please. But the quality of evidence and its strength may not be assessed in CPGs, and often the evidence is not cited, even if it's available. And if we think of the range of symptoms experienced by people who've had a stroke, then the searches for guidelines were wide, but specifically focused on the care and treatment of stroke, and not for the specific symptoms such as pain. So systematic review evidence and positive recommendations suggest there may be some support for the use of acupuncture for a range of symptoms associated with stroke. Can I have the next slide, please? The challenge is to ensure that research underpinning the evidence base facilitates integrated care provision, and this is explicitly linked to clinical guidelines. So in the next slide, we look to see whether an integrated approach is the answer. If that's the case, what evidence should we be considering? And is a One Health approach the answer to improve the health and well-being of individuals? And what is the evidence that traditional medicines improve overall health? What sort of research do we need to demonstrate its benefits? And how can we measure and demonstrate change? And what should we be measuring to show a difference? Is it something like improved well-being, reduction in symptoms? Is it improvements in motivation, energy, or is it actually something like self-management? And the next slide, please. So we need to consider various things. We need to look at whether just using RCTs is valid. What other information is there? Should we be looking at sham techniques when a lot of Western medicine interventions compare with routine care? Should research and the evidence base be more focused on well-being as an outcome measure? And then we need to think about what matters the most to a patient. What are the treatment objectives for patients and the clinician? Patients want to achieve some form of health gain, whether it's being able to do daily tasks like go shopping, cook, but also if they need to be able to look after themselves. There may be mood improvement, stress management. So there are goals that have to be set. So what sort of measurement tools are available to evaluate and measure change? Is there really a universal measure for traditional medicines? Does that exist? What sort of evidence should this be composed of? Is it to do with evaluations of services, qualitative studies, case reports? Next slide, please. Priorities is really to start to look at developing good practice guidelines on traditional medicine research, and to look at the measures of personalized medicine which can capture the holistic aspects and also focus on prevention. The use of syndrome differentiation in TCM as a method of stratification has already been mentioned as a way of potentially changing and improving the designs of clinical trials. Next slide, please. But the concepts in TCM diagnosis actually can change by treatment. They're dynamic. Syndrome differentiation is dynamic. It can be altered after TCM treatment according to the previous diagnostic pattern. So there is a key challenge there. How do we standardize the diagnostic procedure and how do we actually monitor those changes? Next slide, please. Studies on TCM syndrome differentiation by medical disease elucidated biological basis for TCM syndrome differentiation using genomic and systems biology approaches. this is a way of perhaps innovating the accurate stratification of patients, and perhaps we can start to integrate syndrome differentiation with orthodox medical diagnoses. Okay, next slide, please. So in Western medicine, it tends to see the trees, but not the wood. TCM, on the other hand, often sees the wood, but not the trees. So thank you for that. And I'm very sorry the presentation didn't work as well as it should have done. But thank you for listening.
好，非常感谢 Dr.
Thank you very much, Professor Nicola. Professor Nicola has made a very important report for us. She talked about the characteristics of TCM. It's not point to point. It focuses on holistic. We cannot just see the tree, but not the whole forest when we treat a patient. So thank you again very much. And our next speaker is actually the convener of today's meeting, Professor Liu Jianping, Director of the Center for Evidence-Based Chinese Medicine, Beijing University for Chinese Medicine.
Thank you for your kind introduction. My topic, please show my slide. Thank you. This is not mine. Sorry.
Good
afternoon, my colleagues and friends. I will spend the next couple of minutes to review integration of TCM with the Western conventional medicine in China, achievements and challenges.
The achievements in China about integrated medicine first. So why we need to incorporate the both system into one, and because the WHO recommended any state country should incorporate traditional medicine into the mainstream healthcare system. So in China, even the Western medicine is a mainstream medicine, but still Chinese medicine are widely and long historically used in healthcare. And we found some of the weakness and the limitation from Western medicine. So we try to find the solution from the traditional medicine. So this is the first reason why to incorporate both together. And secondly, Chinese medicine can be used in a lot of fields, especially in the healthcare and health promotion, not only the disease, because in the ancient time, it's addressed treat the unhealed conditions. And in China, 1944, Chairman Mao addressed the collaboration between Western medicine and Chinese medicine. So not they conflict each other, but they should collaborate each other. And in 1956, Mao formally addressed that we should integrate the knowledge of Chinese medicine and material medical with the knowledge of Western medicine and pharmacology to create a unique new medicine. So this is nowadays, it's still valid for the development of the integrative healthcare and integrative. So in that year, Beijing, Shanghai, Guangzhou, and Chengdu established the TCM universities by the government. So the development, we have the earliest society, I think, in the world. 1981, we established Chinese Association of Integrated Chinese and Western Medicine. Why in 1990 it's changed the name? Because the integrated medicine should cover all the different kind of traditional medicine, not only the TCM, but also including Mongolian medicine, Tibetan medicine, and other folk medicine. So it's changed the name of Chinese Association of Integrated Medicine. And under the association, we have more than 70 specialty committees, including the Evidence-Based Medicine Committee established 2005. And more than 30 medical universities set up the discipline of integrative medicine at both undergraduate and postgraduate level. And the definition of integrative medicine in China, it incorporates the TCM elements, including diagnosis and therapeutics, into routine healthcare, and also address the wellness and healing, especially the self-healing of the whole person, considering the 5 components, including biological, social, psycho, spiritual, and environment, into clinical practice. And also the integrative model addresses the patient-centered care, and also the approach takes into account the patient complaints, especially thinking about using the EBM idea to considering the patient value and preference. So the way of integration, the first one is most commonly with Western medicine diagnosis and the treating with the TCM treatment. So it's something like we created an alternative therapy for some of the disease. For example, using acupuncture to treat Bell's palsy. And the second model is the diagnosis and treatment used by both systems. So we called it disease and pattern diagnosis. So for example, irritable bowel syndrome, we use the Chinese herbal medicine to treat this condition and also diagnosis. And the third one is using the TCM therapy as a complementary to Western medicine treatment. For example, Professor Robinson just mentioned using acupuncture for stroke, especially in the rehabilitative stage. And finally, using the specific treatment of Western medicine and also TCM individualized treatment to compensate the adverse effects from the Western medicine. So for example, the chemotherapy and also using the herbal medicine to against its adverse effects. So the level of integration, the first one is serious, most difficult, because they talk about in different language. So we think the EBM is a common language for both systems to develop. And second one is diagnosis. And this is commonly used in Chinese TCM hospital because we use both ICD-10 and also the TCM diagnosis. And treatment, like I mentioned, with the comprehensive each other with Western traditional medicine in daily clinical practice. And finally, the modern contemporary scientific research methodology have been incorporated in TCM research, and even the herbal culture and laboratory testing, manufacturing standard, and clinical practice guideline. The achievement in China, a substantial contribution from Chinese medicine, including Western medicine and integrative medicine. So we called it 3 horses in China as a healthcare system. And secondly, establish the education system in the different university and also incorporate the methodology, especially evidence-based approach in clinical research and development of GCP in Chinese medicine. And secondly, what we are facing for the challenges and the strategy. So the first challenge is research methodology. As we understand, it's a complex intervention and including a lot of different dimensions in the traditional medicine. So expert just mentioned several times about individualized feature and also the complex intervention, including the domain of the psychology, spiritual, philosophy, and the context in this field. And also integrative medicine is not just combination, it's an integration of the strengthness of one with the weakness of another. And also we need to explore what is the mechanism to create the new benefit to rather than each individual therapist. And also one of the challenges is the herb-drug interaction. As Marlene just mentioned that actually in Western medicine, drug-drug interaction is also a problem. So what we are concerning about is making it more enhanced therapeutic effects rather than with one to reduce the other one's clinical effect. And also provide high quality evidence that requires substantial funding from both government, NGO, and also pharmaceutical companies. And we need also to consider the social cultural context, especially in East Asian countries. So another challenge in incorporating TCM in clinical practice is the financial problem, barriers, because TCM is cheap and it doesn't make profits from the hospital healthcare. And secondly is the clinical requirement, especially qualification of practitioner and also the quality of the herbal products. And finally, how to make the evidence into clinical decision. So we develop clinical practice guideline and also clinical pathway. For research modality, we suggest that we evaluate the clinical effectiveness first, considering the whole system approach. And secondly, we elaborated what is the components with the complex intervention, and we can develop the detailed design to evaluate specific effect for each individual intervention. And finally, we need to explain what is the mechanism for the interaction of the different components. So in daily practice, why we call it the whole system approach? Because it's considered at least 5 domains: biological, psychology, social, environmental, and cognitive behavior support to the patient care. And for the methodology, we suggest using the quantitative and also the qualitative ways to fairly evaluate the traditional medicine, especially the integrative care, healthcare. So it's included preventive medicine, predictive, participatory, and precision and promotion health. So it's a very comprehensive, including the general conditions and also the complex conditions. So for capacity buildings, nowadays we know that we're using the open science principles to establish the capacity from both the practitioner and also the research. So we encourage the collaboration between the researchers and also the practitioners in this field. And also a lot of more research toward the real-world pragmatic studies, because we want to learn how patients get benefit from the integrative approach. And also in the future direction, we suggest to identify some prioritized disease or conditions for integrative medicine. And secondly, using an evidence-based approach to evaluate therapeutics and the safety of integrative medicine. So some of the methodology like healthcare, health technology assessment, and even the artificial intelligence technology in this field. And also executive pragmatic study address the cost effectiveness and health service research. And finally, developed a multidisciplinary model for healthcare and established evidence base for integrative healthcare. Thank you very much.
Thank you so much, Professor Liu, for your wonderful presentation. You will talk about yesterday, today, and tomorrow of integrative medicine, challenges and strategies to overcome these. In the next discussion session, we will talk about it. How to make it 1 + 1 / 2? How can we make it more effective and cost-effective? We will have 3 panelists joining us on this discussion session. First, let's welcome Professor Duan Yuting. Hi everyone, I am from the affiliated Regional Chinese Medicine Hospital of Guangzhou Medical University. In August 2023, and reviewed by Professor Franco, I joined BMJ as Associate Director of EBM. BMJ. I also work in the TCM hospital in Guangzhou, affiliated to Guangzhou Medical University. Our hospital is rather special because we are affiliated to the TCM hospital, affiliated to a Western Medicine University. That's why we are shouldering a lot of responsibility in integrative medicine practice, education, and research. So that's my special role. We are facing with a lot of challenges concerning generation of evidence for TCM. So this topic is really related to my day in and day out clinical practice. How to generate high quality evidence for TCM and how to translate it into practice and policy. For me, personally, from the perspective of our journal, I'd like to share with you some of my thoughts. Standardization and internationalization are very important. We need to formulate a clinical guideline and a reporting system for standardization.
Acupuncture has the highest international standards and is recognized the most throughout the world. Before I came here, I was working on some statistics. As of now, as of the latest publication, we have admitted 6 papers, accepted 6 papers on acupuncture, 3 papers on alternative medicine and non-medication therapy. And there are also some papers published in this area too. So far we haven't got very original research on the TCM formula and the integrated Chinese medicine and Western medicine. So this is still an area worth more exploring. Professor Liu was talking about the integrated TCM and Western medicine system and the way to integrating them together. I think that's a very important thing. And it's also worth considering whether we can have an international paper, a journal, to serve as a platform. Because to make TCM more influential, we do need an international platform to publish these papers and relative standards systems too. From our journal's point of view, we have accepted a lot of evidence-based tools and especially about guidelines. We tend to publish the evaluation tools with international mutual recognitions, with international consensus. Professor Lee is also here today with us. We would more consider conventional medicine, including traditional Chinese medicine and traditional medicine in Southeast Asian and in South Korea too. In terms of data sharing, BMJ has the most strict data sharing policies among the 4 major medicine journals. It requires all the clinical trial data to have DOI and put the data on an open database. Now, BMJ is playing a leading role, and as a subjournal of BMJ, we're also moving towards that goal. And a lot of experts have also mentioned patients' participation. The BMJ also requires, we cannot say not possible to include the patient, to reject the patients from the clinical trials. I think to TCM researchers, TCM is actually a better area to include PPI. That's my thoughts. Thank you for listening. Professor Duan has given her insights from the point of view as an international medicine journal, including standards, including strengthen international consensus and implementation, and we need to have an international platform so that the relevant plans and ideas can be shared with the other people on this international journal. These are two very important inputs. Thank you again. Next, we're going to invite Professor Yan. Dear experts, I am from Beijing University of Chinese Medicine. I'd like to speak about my views from 4 points. For the synergy between TCM and Western medicine, I think we have to follow a basic principle, which is we should be efficacy and effectiveness oriented, patient-centered, and high-quality evidence-based to better integrate traditional Chinese medicine and Western medicine. I think that is a mutual goal for TCM and Western medicine, because ultimately what we are seeking is patients' benefits. Patients can actually benefit from our effectiveness. And secondly, in terms of methodology, I mainly work on methodology, so I will share some of my insights. I think now we are more focused on evaluating the specificity. However, we have recognized that TCM plays more of a holistic role. And now we do not have that many studies on the holistic role of TCM. So in order to promote the integrated medicine, the holistic role of TCM must be a obvious advantage of us. And TCM has very good clinical resources in China, because when we are checking on the patient, a lot of doctors would take integrated TCM and the Western medicine approach. So I'm saying we need to work clinically and decide what is the main advantage with the integrated medicine and try to give it a better play. We should find a better position for integrated TCM and Western medicine in our existing medical system. And so far, we are still lacking high quality evidence, because now we are still working on RCT studies mainly. I think this is not a good idea, because in that case, TCM has its own evidence and the Western medicine has its own evidence. And these two evidences are isolated from each other. So we need to think how we can either combine them together. We've done some really good studies with acupuncture, as do I. We've done some trials on combination of acupuncture and drugs. I think that's a very good area in TCM, because first of all, in international arena, acupuncture has very good accessibility, because acupuncture has been made legal in many countries. In the US, there are also a lot of centers who are allowed to give acupuncture treatments. We've also done some clinical studies on combining acupuncture with other medications. Combining acupuncture and medications to treat high-risk populations, vomiting and nausea after operation, because post-op vomiting and nausea can be quite common in certain populations, like in females, when they're doing laparoscopic surgeries. In Western medicine, we can use some medications to treat that, but for this highly risky population, a single drug cannot get their symptom under control, so we need to use combined therapy. But combined therapy brings adverse events. Western medicine has clear targets and effective channels. So it's hard for these monomers to cover all these different channels that may lead to vomiting and nausea. While on the other hand, TCM plays a holistic role. It can give the effectiveness from a lot of different channels, so it may be able to cover all these channels that a single monomer cannot cover. I think this kind of combination can be easily combined with existing clinical trials, whether in China or in other countries. For this, the China University of Chinese Medicine has done a lot of studies. They integrate TCM with modern anesthesia. I think that's a very good scenario for integrated medicine. Under the ERAS background, we hope our patients can have a better outcome and be discharged quickly. So acupuncture can be very effective in there. It has good post-op pain control effectiveness. So I think we have been enlightened and inspired by our experience with acupuncture. We should always think about our clinical demand. What kind of scenarios require more TCM engagement, requires more integration of TCM and Western medicine? So we should look at our clinical practice, identifying the existing gaps and try to find high quality evidence. By doing so, we may be able to find high quality evidence from clinical practice and then use this evidence to guide clinical practice. To make innovative synergy, I think research methodology should focus more on real-world studies. Because when we talk about integrated Chinese and Western medicine, we focus more on the holistic effect. So from that perspective, the real studies has its own advantage. And we do have a lot of clinical resources when it comes to integrative TCM and Western medicine, so we should give them a full play. In addition to generating high quality evidence, I think this evidence can be used back in clinic too. Now, in China, we have attached great importance to real world studies. However, we do not have that many high quality ones yet. I think this has something to do with the fact that we didn't have a lot of high quality clinical studies previously, but now a lot of Chinese experts, clinical hospitals have come to resolve this problem from the root. And as time flies, I'm sure our real studies will become better and better and will bring us more high quality evidence. And we also need to expand further in terms of methodology because real studies involve a lot of complicated statistical methods, bias control methods. So we do need to catch up with the international pace. And also, mechanisms are also important. Now we've begun to give attention to acupuncture, but the other things are important too, because I think both the efficacy and the mechanisms are both important for TCM. The efficacy and effectiveness is our ultimate goal, while the mechanism is something that basically link everything together. So we also need to work on the mechanisms, the underlying mechanisms of TCM2. I think Dr. Merlin's study was also very interesting, and I'm very interested in this. We've also made some choice in this aspect. We've also explored how we can do better in the syndrome differentiation and how we can evaluate TCM effectiveness considering this characteristic. But it's really difficult. Just like Professor Merlin said, it's a great challenge, but I think it's something worth exploring because it's something that can truly reflect TCM's characteristics. I hope if we can have more opportunities, we can have more in-depth discussions with Dr. Merlin and learn more things from him. That's all I'd like to share. Thank you. Thank you, Professor Yan, for everything you shared with us. All the 4 points are very good points. From macro parts to micro mechanisms, all great insights and all very important tasks for us. And next, we're going to bring Professor Cao Huijun to give her insights. Well, our 2 UK speakers, are they listening to the interpretation? Yes, they do. Very good then, I will speak in Chinese. Our thing today is about integration mechanisms of TCM and Western medicine. So it emphasizes not only addictive effect. If we want to do better in TCM research, I think there are 3 major challenges. Some opinions have been mentioned by previous speakers in the panelists. So I want to give some simple thoughts from my point of view. First of all, Professor Guo Xingfeng and Professor sorry, I can't remember which professor mentioned the type of disease we choose to adopt a TCM intervention is the first thing we should consider. That Professor Guo mentioned the Tai Chi Chuan. He says we have been using Tai Chi to treat acute neural pain, but is it only used to treat the nerve pain? I know that they are mainly focused on the pain scores, and it used acupuncture. This study I'm referring to used acupuncture on pain control. But the other relevant indicators are not discussed in that research as key points. So now when we're looking at integrated TCM and Western medicine, we are looking more at the effectiveness from the mainstream point of view. But that indicator, that single aspect may not be the aspect that TCM is taking care of. So I'm saying that maybe not all types of diseases are suitable for adopting TCM Western medicine. And also, most of the researchers may have neglected something, that is the health economics evaluation. So all the benefits we are gaining now, do they mean that they are actually generating more cost while bringing the patients more benefit? Now, if we look at a lot of GI cancer studies, we may see that they have prolonged the survival time, but they haven't considered the economy of these new drugs. So I think the health economics is also something we should consider when we look at integrated medicine. And also, the time of intervention is also very important. In the past, when we were doing this kind of evaluations, we had a study on using TCM to assisted reproduction. So if we give the TCM can be given before the IVF or after the IVF, but we haven't seen any discussions on which timing is the best. We can only discuss this question from sub-analysis.
Previously, there was a study on herbal medicine to treat COVID-19. If it is administered within 72 hours, it can improve and reduce the rate of acute exacerbation. But if it is administered after 7 days, then the efficacy was gone. The timing of traditional medicine intervention is another key issue. Thirdly, a very controversial aspect, some of you have already mentioned, to evaluate the traditional medicine evidence, what methodology shall we use? Previous researchers have mentioned the assessment grade tool. Maybe we need to integrate TCM features to have a new version of evaluation criteria so that it is more suitable for TCM and other traditional medicine that has a complicated intervention system. A lot of traditional medicine intervention, after evaluated by grade, the level of evidence will be reduced because the methodology per se has limitation or because of other reasons. Complicated intervention may composed of multiple drugs, multiple prescriptions. We fail to clarify the interaction and the mechanism behind. That's why the level of evidence is compromised. Researchers mentioned based on this, for complicated intervention, herbal medicine is complicated itself. If we're going to combine with Western medicine, it's going to be more complicated. Can we have a new set of rigorous evaluation assessment criteria for this integrative medicine? Maybe we need to do it in the near future. I'm not saying grade is not holding water. I'm saying that we need to roll out a new evaluation tool for integrative medicine. I think that's a question we need to address in the field of integrative medicine. Professor Fei also mentioned some other tools. a good try, a good beginning. So the above-mentioned three challenges, like the selection of most appropriate symptoms and disease for assessment. Second, the timing of intervention. Thirdly, the use of assessment tool. These three challenges need to be addressed. However, challenges we are facing will go beyond these three. There are other factors that will impact the assessment and generation of evidence in our field. However, in terms of a methodology, we do need to consider these key areas so that integrated medicine can be effective, cost-effective, and supporting decision-making. Thank you, Professor Cao. You have mentioned the three common challenges. One thing is pharmacoeconomic analysis. So we can have better efficacy maybe because of integrative medicine, but is it pharmacoeconomically benefiting? We have heard three great keynote speakers, and we have here from three panelists. I will conclude this session for the sake of time. How can we have energetic mechanism for integrative medicine? We need to have evidence-based medicine and to explore more solutions and more ways out. I have listened to our speakers in this session. There is a need for sure. For traditional Chinese medicine and traditional medicine as a general, there is a need in the market. And the traditional medicine have solutions. However, challenges and opportunities are coexisting. We have a wonderful discussion as well. I'd like to echo Professor Duan as well. Can we formulate a system so that we can discuss about it in a deeper, in-depth fashion in your journal? One of the key is that the interaction between drugs. This is a question that we must address. A very important question to address as well. Based on integrative medicine, step by step, I think we will tackle and overcome these challenges one at a time in terms of designing and also evidence translation and in other aspects. I will conclude my session. Thank you. I will hand over the microphone to the next moderator, Professor Han from the affiliate Traditional Chinese Medicine Hospital of Southwestern Medicine University. Thank you, President Zhang, for a kind introduction. It's my great honor and a pleasure to come to the capital city of China, Beijing, and to meet you here. I learned a lot. I learned quite a lot today. In the first session, we have discussed methodology, constructing high-quality evidence framework. The second session, we focus on beyond addictive effects. In the third session, we're going to discuss translating evidence into practice, strategies for implementing TCM interventions in clinical settings. It's a great honor to have invited academician Tian and President Liu to be the keynote speakers in this session. First, let's give the floor to academician Tian to give us a presentation. Welcome. Academician Tian has a pre-recorded video.
Hello, everyone. This is Dr. Tian from Department of Neurology of Dongzhimen Hospital, Beijing University of Chinese Medicine. First of all, I would like to thank my good friend, Professor Liu Jianping, for the invitation. He is a famous expert in evidence-based medicine. This time, I'm going to talk about my work named as a case for translating evidence into a guide to practice. I am a clinical physician, but in response to the clinical needs in my field, my colleagues and myself including Professor Liu Jianping, have attempted to make some clinical practice guidelines in China, including rules for traditional Chinese medicine. How did we formulate the guidelines? I would like to report on our methods for developing the guidelines use Alzheimer's disease as an example, referring to as the 5 steps. First step, outline framework. This is preparation of staging, which requires answering the medical problems that exist throughout the entire process of sentinel disease, including answering why this is a need to creation guidelines for the integration of Chinese medicine and Western medicine. As we all know, the causes of dementia are diverse, among which Alzheimer's disease is the most common, accounting for about 17% of all causes of dementia. In our country, the number of AD patients accounts for the 1/3 of global total, with the mean diagnosis rate as high as 85.6%, for exceeding the global average of 75%. This indicates that in the formulation of AD guidelines should focus on the diagnosis issues. Furthermore, the challenges faced in the treatment of AD are even more severe, existing symptomatic therapy such as cholinesterase inhibitors for mild and middle AD is only 6 months of the effective duration. Disease-modifying therapy such as nuclear for any AD is only 27% of slowing clinical progression in 18 months with a severe adverse effect. In China, the use of traditional Chinese medicine to treat dementia has a history of 2005 years, from the time of Huangdi Neijing through the Tang Dynasty, Ming Dynasty, and Qing Dynasty, and so on modern research. A relatively mature system of treatment has been established, such as the sequential therapy we developed, which stages treatment according to the progress of the disease. Both single therapy and sequential or combination therapy have received clinical evidence support. Step 2 is evidence collection, including thematic search, evidence screening, and quality evaluation. During this time, we published individual papers and received comments from peers around the world. Step 3 is content formulation, which includes the results of the meta-analysis and systematic review, forming the main evidence and recommendations. From 4,391 original studies on traditional Chinese medicine from treatment of AD, 31 studies were included for combined data analysis with 3,703 subjects. There are also 6 studies with evidence that can't be combined. Step 4 is external review, including the external modification opinion and recommendations and consensus of the peer experts. Based on the evidence and the consensus, 10 recommendations were deleted from the initial proposed 27 recommendations, resulting in the final total of 77 main recommendations and 42 secondary recommendations. Stamp 5 is released and promotion for this guideline. China guidelines on AD dementia diagnosis and treatment recommended a sequential swapping with characteristics of TCM, which has been jointly released by 3 national societies of China. The National Administration of TCM held a press conference to promote application to more than 3,000 tertiary hospitals nationwide. This is just an action, and our goal is the translation evidence into practice to benefit more patients with TCM. That's all for today. Finally, I would like to thank my team members for their long-time support, and also thank every expert present for your patience listening. Thanks a lot. Hello, everyone.
好，非常感谢我们田院士
Thank
的
you very
精彩
much,
的
academician
讲
team,
座。
for your
那接下
excellent
来呢，我们有
presentation.
请
And
刘清
next,
泉
we're
刘教
going
授
to bring our next speaker, Professor Liu Qingquan.
好，非常感谢大会的邀请。
Thank you very much for inviting me to this
根
meeting.
据咱们大会的要求吧，我想
As per the meeting's requirement,
重要的一个
or assigned by the meeting organizer, I'd
那么
like
一
to
同治这样一个
talk about a modern TCM example
那么
journey
这
from clinical recipe
对
to
于
treating
急性
diverse
的传会的
diseases.
传染病，中
For
医
acute respiratory
非
tract
常丰富的
infectious
经验，也
disease,
有非常好
TCM
的
has very rich
传承几千
experiences
年，
and very
从麻
good
杏子甘
formulas
汤汉
that
酒
have been
到银
used
翘
for
散，
thousands of years,
我们清
from
朝
Ma Xing
到
Gan
白虎山
decoction
也是汉
to
草，
in Han
这样一
Dynasty
个
to
南方
Ying Qiao
提出了
powder
中医
of
外感热病
in Qing
还有
Dynasty,
疫病、瘟
which
疫
are
这样
used
一个有效的一个处方。
to
这样的处方呢，可
very
以说在
useful formula
中
in
国几千
treating
年的大规模使
fever-related
用，解决
and
了非常多的
hotness-related
一个问题。那么这样
diseases.
一个
They have been used in China
中
for
医的一个问
thousands of
题，
years and
在
have
现代医
resolved
学
many
这样一个
problems.
发展过程中，它
And
产生
now,
了重视
together
走来
with the
进去
Western medicine
去
development,
去探索去。
where
那么在
TCM can give
09
display
年、10年讲
how
座期
it
间，
can
那
serve
么
the
我
modern
和
patients.
王晨
Back
院
in
士还有长安院
2009,
和朱志
during
文
the
院，
influenza
那么就
A
这样一个处方呢，
H1N1,
开展了
me
H1N1。那
and
时候那个
Dr.
年
Wang
代
Chen's
是
team
没有药可治的情况下，
collaborated
我们开展了一个
and we
这样一
conducted
个处方和
a research on
对
using
对
this
甲的
main
这个一个
formula.
临床治疗研究，最后呢证明了呢，
And
它和
finally,
奥司他韦
we proved
疗效一样，而且在解除临床症状方面比奥
that
司
it
他韦
has the
更好。
same
那么这个研究最后结果呢，也
efficacy
发表在
compared
学
to
界。那么
oseltamivir,
基于这样一个结果呢，
and it has better
我们
performance
开
in
展了
terms
这样一个
of
新药
adverse
的研究。
events
那么这
compared
个
to
处方能不
oseltamivir.
能做成一个新药来
So
治
now
疗
we are
甲
conducting,
型
this
流
is
感
a
这样一个。那么这个研究
clinical
呢，
trial
也开展
conducted
了那个
on whether we can use this
获得
old
了几个奖。随后
formula
呢，就
in
开展了2
treating
期、3期
influenza
双
A,
盲安稳剂
and
对
then
照
we
这个实
did
验，这个
phase
实验
2
呢，
and phase
总共
3
拿了
randomized
1370
double-blind
人。
placebo-controlled
那么
clinical
最后呢，
trials.
证明了
It
这个药
involved
是有效的，
1,370
是
patients,
可以
and
治疗
finally we
甲型。
proved
那么
that
这
this
这个
drug
药呢
was
就
effectiveness was
面
e-
世
e-
了，就成为一个中成
was
药面世。这中间呢，经过了7年的
has
一个时间，
effectiveness
也
for
就是说，
influenza
中
A.
成药里
It
面
took
治疗
7
甲
years.
流的一个药，这是其中之一。当然，那个
So
研
this
究
is
也证
one
明了
of the
奥司他韦也可以治疗
TCM that can
0910
treat the
年的
influenza
新型
A
的
H1N1.
H1N1 这样一个流感型。
We proved both the efficacy of the Western medicine and the Chinese medicine. And the Chinese drug has better performance in dealing with the throat pain and the heat dissipation. Now this drug has been launched into market. So this was a drug used for influenza, and then in 2020 we had the COVID-19 outbreak. Based on the COVID-19 characteristics, from TCM point of view, it has almost the same disease characteristics as the three main decoctions I just mentioned treat. And I did a study in Wuhan. I used 7 days to recruit over 80 patients, and we proved that this Jinhua Qinggan granules was effective. Only I doubled the dose. We used only 1 pack for treating influenza, and we used 2 packs to treat COVID-19. And it was proven that it can treat the COVID-19 symptoms, including fever, cough, fatigue, and sputum. And we see a much lower rate of turning into critical cases, severe cases. And those severe cases didn't die, while those treated with only Western medicines had a certain degree of mortality. At the beginning of the COVID-19, all the patients in the Wuhan were sent to the Jinyingtan hospital, and I was also in that hospital. So I personally observed the change in mortality. In the same period of time, we also did a study in UN hospital in Beijing, where we had an outbreak of the original strain, and we only used 1 pack, the same as influenza. It was also demonstrated that this granule could reduce the rate of turning into severe cases, and it has also demonstrated good efficacy in alleviating all the symptoms. So it has been proven that it is effective in Chinese populations. But what about in other countries? We collaborated with Pakistan University. We also conducted the world's first international multi-center randomized double-blind placebo-controlled registered clinical trial. And we used 10 days to incorporate 300 patients. We focused on the clinical symptoms. The group used the Jinhua Qinggan granule had a effective clinical response rate as high as 82.67%, while the placebo group saw a response rate of 10%. At the beginning, the Pakistan people were very reluctant to take this drug because it was very bitter. But when they saw its efficacy, they became very happy to take this drug. They became very open to this. Of course, we treated different strains in China and in Pakistan. We treated the original strains when we were conducting the studies in China. While we were doing this in Pakistan, we had both the original strains and also the Delta strain. The main problem, or the only problem with this granule, is its taste is really bitter. So their pharyngeal doesn't feel so comfortable. But otherwise, it has basically no other adverse events. And the Hong Kong Baptist University the Consortium for Integrated Anti-Epidemic Research has also published the paper about Jinhua Qinggan granules significantly lowering risks of severe COVID-19 progression. So basically, we have proven its effectiveness both in mainland China and in Hong Kong and in overseas countries. So these are some therapeutic characteristics with Western medicines in COVID-19. In early stages, it's mainly experience-based antiviral regimens like the remdesivir and the ritonavir interferon, because we didn't have other options back then. And then we began to try using glucocorticoids. It could reduce mortality rates. And we also used other drugs like baricitinib. And then we began to use other drugs like anticoagulants. So these were the conventional drugs used in COVID-19 management. The glucocorticoid study was a very important one. It proved that the Western countries have established a great platform when there is a major epidemic outbreak. Whereas in China, we haven't established such a good research platform. So a lot of Chinese studies cannot establish very sound results. So this is the drug that can treat both influenza and COVID-19. These were two types of diseases caused by two different viruses. So this comes back to a major principle of TCM, which is treating different diseases with the same therapy. Because they demonstrated the same therapeutic principle, they manifest the identical pathodynamic patterns. Therefore, we can treat two different diseases, these two distinct diseases with the same drug. So once we fully understand the mechanism of the disease, we can be successful to treat different diseases with the same medications. In the influenza, it was the H1N1 virus, and the population had the same symptoms. And if the symptoms change, that means it has turned into a different disease. And it was basically the same with COVID-19. The only difference is we had different strains, from the original ones to Delta to Omicron. But the most basic features of the virus stays the same. They could be summarized as wound heat invading lung, toxin heat, internal accumulation. So we could use the same treatment plans. So these were the Maxing Shigan soup, originated in the East Han Dynasty. It has been over 1,000 years. Of course, we can use the other decoctions. As long as they use the same therapeutic principle, we can use any drugs that can clear the heat and resolve the toxins, that can ventilate the lungs and dissipate the phlegm. The biggest advantage with TCM is that we have so many decoctions, we have so many different combinations, we have so many different elements. So that's the biggest characteristic of TCM. We can treat different diseases with the same therapy, and we can treat the same disease with different therapies. This helps us make better preparation for those potential epidemic that has a rapid outbreak. As long as we see the patient, we can always come up with a suitable therapy. Because as long as we can understand the principle, the mechanism of a disease, we know what kind of therapy we can use. Like for the original strain of the COVID-19, we knew that the basic mechanism was humidity and the toxin. And when it came to the Delta strain, we began to have heat too. And when we had the Omicron strains, the heat became even more significant. So that's the change across different strains. And we also saw different geographical features. Wuhan was a more humid and cold place, and Guangdong was a humid and hot place. And in the northeast region of China, we had other geographical features too. It was dry and cold. So whether it's Wuhan or the south area or the north area, they were not directly related to the viruses themselves. These were geographical features. Just like I would wear different kinds of vests in different places. I may wear a black vest, I may wear a red vest. But the vast is not myself. I'm saying that the TCM can treat different features of a disease, but ultimately speaking, it's all the same type of disease. So this is a mechanism review of using TCM for prevention and treatment of viral pneumonia. We have sorted out the traditional Chinese medicine symptom patterns associated with the viral pneumonia caused by different pathogens. And we can see the same targets in multiple TCM formulations. So we have to study the TCM formula as a holistic system. The mechanism one is antiviral action. Of course, it's unfair to say that the TCM cannot kill the viruses. It's not killing the viruses as quickly as the Western medicines can do. It's like hitting the viruses with a stick, and the viruses will collapse. It's not like killing the viruses, but it does have a certain degree of antiviral actions. And we have used some modern mass spectrometry tools to identify the exact components of this formula, which shows that this formula also have a certain degree of antiviral effectiveness. A second mechanism is immunomodulation, because the COVID-19 is different than influenza in that it can significantly affect the patient's immune functions. It can impair the patient's immune functions significantly. So by suppressing the cytokine storm, we can reduce the viral pneumonia mortality.
既有共性的特点，也有各自的特点，也就是说每个人还有每个人的特点，但是不管它什么特点，从中医看。
Different pathogen has different features, but it may look alike in a TCM concept. For COVID-19, we have multiple formulations. 3 medicine, 3 formulas were recommended by the National TCM Bureau. They don't have superiority from one to the other. Like in different Chinese cuisine, Chinese food, we have a different class, but they all taste good. For each meat, in Sichuan, it's like a hot pot style. In Beijing, we have a different cooking style. And in other provinces, you have a different taste. And which one is the best? There's no answer. We cannot say the Sichuan cuisine is the best or the Cantonese one is the best. The same in traditional Chinese medicine. If we grasp the principle, we can use the same component in different formula, right? This is just one example showcasing the same essence and principle. If they work in the same pathway, it all works. All the new formula and compound are examples to show you the principle. We have hundreds of formula being rolled out during COVID-19. They shared the same principle. We can have one principle, but hundreds or even tens of hundreds of formulas. This is the difference between TCM and Western medicine. Symptom differentiation is no easy peasy, not an easy piece of cake. We need to have a lot of work in terms of research. But if we know about the diagnosis, we have a confirmed diagnosis. If we have a confirmed treatment. The thing is that we have a different formula and different solutions. It can be catered according to geographical area and according to constitutions. That's the essence of a TCM, seeing the symptom and trying to find the root cause and to treat the root cause. If we can tackle this level of the problem, I think others will follow. If we know about the principle, then the formula can vary. We need to make confirmed diagnosis, confirmed the principle. And the drug's formula can vary according to your experience. If we cannot make a certain diagnosis, then we don't know about the principle, and then we don't know the root cause, let alone the treatment. At this point, there is no symptom differentiation. So that's my key message I want to convey to you. The drug can vary based on the same pathogenesis. Thank you for listening. Thank you, Professor Liu, for your wonderful presentation, and a lot of key messages were conveyed, combining with your own clinical experience. Now, let's dive into the third discussion session where we have invited three experts. First is Professor Li Jian, President of Guang'an Mental Hospital of China Academy of Chinese Medical Sciences. The second one is President Jia Xinhua from the First Affiliate Hospital of Shandong University of Traditional Medicine. The third one is Professor Zheng from Longhua Hospital. According to the sequence, let's first invite Professor Li. Thank you, Academician Tian and Professor Liu, for your very wonderful presentations. Combining with your clinical examples, how can we translate the effective formula into evidence? Research for TCM has a large audience. Professor Tang also mentioned why we still need to generate such evidence to make it more acceptable. Don't forget about it. Traditional Chinese medicine only accounted for 20% of all healthcare institutions in China. That's why we need to advance with the time, advance with the modern science to generate high-level evidence. Against this backdrop, I do agree with you. First, we need to identify the needs and demands. Secondly, we do need to find efficacy and effectiveness of our formulas. Why? The guidelines have a poor implementation because the efficacy is not that good. Based on efficacy and effectiveness, can we better popularize the guideline? That's the key for evidence generation and translation. I am an oncologist. I have been visiting the MD Anderson for 2 years. So I know the pathogen and the pathogenesis of a tumor. In the last 6 decades, from the 6th five-year plan to the 13th and the 14th five-year plan in China, I have led a lot of key programs. Despite the 9th five-year plan, it was not conducted by my team, but others. We have a lot of programs. TCM to treat cancer. Oncology department in different provinces have a participation in our program. They have the clinical needs, but what's the real role of a TCM for oncology? From 2006 to 2010, Professor Lin has organized national multi-center study. From the cohort study and RCT are conducted simultaneously. We validated in advanced lung cancer, stage 3, stage 4, and postoperative patients. Comprehensive regimen can significantly reduce the 2-year relapse rate by 6%. For stage 3 to stage 4 patients, we can elongate median survival 3.6 months. At that time, we validated what? In a large population base, integrative medicine was efficacious. However, it was a very complicated regimen, leading to a greater challenge in publishing our data. Because the editor says there is a lot of heterogeneity of your regimen. We cannot make it standardized. That's why, coming to the 13th five-year plan, I led another national fund program focusing on a precise population. Stage 3 to stage 4, oncodriver mutation negative, not suitable for immunotherapy. One group received chemotherapy, the other received chemo plus the TCM. This is a TCM injection, which has already been approved in China. After 3-year follow-up during COVID-19, participated by 30 centers, 300 also participants, showing that the chemo plus TCM group can elongate the PFS. That is to say, our parameters are very close to the international guidelines. We are using progression-free survival. For those older than 60-year-old, especially among male, we elongated even more about the survival, boosting confidence in us and providing with us a high-quality evidence. We are summarizing the data. Hopefully, we can publish it as soon as possible, really validating the efficacy of a TCM in a RCT study. But we're facing more challenges as well. We have a lot of clinical needs for the post-operative setting. We have a lot of patients undergoing surgery. The key issue after surgery is prevention of metastasis. Lung cancer, stage 2, 5-year relapse rate 50%. Stage 2 is rather early, right? But after 5 years, half of the patients will be relapsing. For this patient, what's next? This is a biggest issue we're facing. Based on this, I have carried out the 2 national RCT, one on gastric cancer, the other on esophageal cancer. These post-operative surgeries, post-surgery settings, we need to find the key issue. All roads lead to Rome, but there is sure to be a shortest cut or shortest way. The young deficiency patients are more prone to problem, and we characterize this patient, proposing our regimen. We optimize prescription, and we roll out our TCM regimen for the young deficiency patient. And we found in a single-arm study, the relapse rate was reduced. And a multi-center study will be carried out. Recruitment was completed. Focusing on this question, we have conducted a similar study on esophageal cancer. Esophageal cancer and gastric cancer have a high prevalence in China. Over 50% of all global patients are in China. That's why we have conducted this study. First, we need to know which drug is efficacious with a rigorous design and to roll out and generate evidence. That's the first thing. Secondly, there are some challenges. As we all know, we have a lot of compounds and a formula, and formula is widely used in clinical practice. Formula is the most efficacious one as well. Why? Because it's individualized. However, with the deepening of disease understanding, we know more about the pathogenesis. Based on this, patients will have other comorbidities and other symptoms and signs. How to deliver, we need to have a combination and also de-escalating for some patients. Endpoints-wise, we need to focus on not only relapse, metastasis, but also quality of life, which is rather comprehensive. We hope that for complicated intervention, complicated efficacy endpoints, we need to have a composite endpoint. In 2015, I wrote a guideline for TCM study and reporting. 3 indications were proposed. First, cancer treatment. Second, cancer auxiliary treatment. That is additive treatment. Third is to improve symptom. Pain, fever are the 2 highlighted issues. TCM has shown great efficacy in this area. So, syndrome is a series of symptoms. For these syndromes, how can we conduct a related study to answer clinical questions? That's the key issue. We need to elaborate and also clarify the mechanism of a TCM, but it's rather complicated. There should be pathway to show mechanism of a TCM, not only related with the immunity, but also with the metabolism. How can we make clear picture of the mechanism behind TCM? That's the second challenge. Third, in terms of strategies and solutions, meeting like today's is very important. We need international collaboration. We need international perspective and a vision to find a solution together, to roll out the symptom, to improve level of evidence. So against this backdrop, what I feel like is that we need to establish examples that has already shown efficacy and the safety profile. and then to have a very good overarching design. For the very beginning, it's positioning, the whole course management, and endpoint design. We need to design beforehand so that the results and evidence we gained will have a higher level. We need to go beyond the challenges that we have encountered, like syndrome, PRO, different endpoints of survival, weakness and deficiency. We need to focus on it. Does all the cancer patients need all these cycles of chemo? I feel like at the end of the day, patients have more pain than relief, not benefiting from these many cycles of chemo. What can we evaluate? How can we maximize the benefits of a TCM for these patients? This is another key point we need to go moving forward. Thank you. That's all from me. Thank you, Professor Li. You have mentioned a lot of points that I do echo. Now let's welcome Professor Jia. Thank you. It's my great honor to be here. I really learned a lot. I've listened to all the speakers sharing, and you have touched upon a lot of points. I do echo with all of you. I see the panelists for this session, the three of us, we have a double identity. We are manager of the hospital and we are coming from a clinician background. There should be a reason to put us three all together for this session. I would like to share with you from the perspective of a hospital manager and also from a clinician. After listening to today's keynote speeches, Professor Liu, Professor Wilcox have a talk about the two drugs. One is 书生解毒, one is 结清散. I use it in my clinical practice. Very efficacious, very effective in practice. In the influenza season, if we have see this epidemic, for recommendation, I will recommend this too for my patients, including 莲花清瘟. Why? Because they're efficacious.
As President Lee said, they are indeed effective in clinical practice. So when we talk about transforming evidence into practice, the first important thing is it has to be effective. Otherwise, it's impossible to translate them into clinical practice, no matter how good evidence you've got, because doctors do not recognize them, the patients do not recognize them. So no matter how high the quality is, if we cannot make them we cannot translate them into clinical practice, then it's not good evidence. So, considering that, from a clinician's point of view, as long as something is recognized by both the doctors and the patients, then it can be put into practice. Together with strict and careful methodology designs, these therapies can be put into clinical practice. But we also know clearly that there are some integrated TCM and Western medicine guidelines and consensus have been written, yet they cannot be put into clinical practice. We have a huge of guidelines like this. So we have been reflecting on this, and we've been talking to the associations. These associations have been aware of these issues, and they are considering how they can better promote these guidelines nationwide. And we are also thinking about this, why we cannot bring this to practice. We are also writing consensus, we are also writing guidelines, and we have discovered some issues from this process. We do lack literature and references that can be used as evidence. And even though we have some literature, their evidence level is still very low. So, with that kind of evidence, can your guidelines be widely accepted and recognized in the medical community? And are they truly effective? If not, it's very hard to promote those therapies in clinical practice. So, I agree that we have to improve the level of our evidence. What kind of evidence are we looking for? whether clinically or from basic research, we have to get very convincing evidence together with clinical effectiveness. That's my insight from a clinician. And as a manager, Professor Liu Qinghua, when he was in Wuhan, I was in the city of Huanggang in another province. I also brought a few nurses with me, and we shared the same feeling. The scientific questions arise from the clinic, from the clinical practice. And we have to have organized scientific research. But when I was working at the front line, I had this feeling that when we were hit suddenly by the COVID-19, we haven't got very robust platform. We haven't got a robust system to guide us through the design of the clinical trials. So we made a very rough and very poorly designed studies. Those who had TCM, those who didn't have TCM, two groups, very simple. And the results were very straightforward. Those who had TCM could be discharged earlier with smaller symptoms, with less symptoms, and a quicker recovery. So we discussed these results with our mass and medicine experts. Although the design of the study was very rough and simple, we did see very good results. But that brings another question to us. Now we've done this, now we've got the COVID-19 under control. Can we make this thing more, can we give it a full play? Can we further expand it to a bigger picture so that these therapies can be more influential, can benefit more patients of different diseases? We have encountered so many cases in our clinical practice. Those who are mildly ill, those who are severely ill. But with these practices and observations, the real question is how we can consolidate some theories and some results that can truly benefit more patients. Thank you, Mr. Jia. He is both a medical expert and also a great leader in a hospital. So our next speaker, our next panelist is Professor Zheng. Hi everyone, I'm from Longhua Hospital, Shanghai University of Traditional Chinese Medicine. I am the last panelist today. Actually, I started on evidence-based medicine many years ago. I went one of the professors today before the meeting, and we talked about our experience back in 2006. He held this lecture back in 2006, and I was one of the attendees of the lecture. And also in 2003, when we were hit by the SARS epidemic, I was also a member of the National Bureau of Traditional Chinese Medicine, and we were working on a guidelines on standardizing TCM clinical trials. I am not a very smart man, and also after 2009, I began to undertake another job in a kind of bureau that is sort of the biggest hospital administration in Shanghai. All those big hospitals are in our charge. So I've been in charge of this task for 8 years. Therefore, when I am giving my inputs, I'd like to talk about this from several different perspectives. First of all, when I know a lot of leaders would have this question. If a doctor can see a few dozens of patients every afternoon, and we have all these numbers, how many outpatient visits, how many surgeries every year. So my leaders ask me, now we have so many cases, why are we not making our own sounds on international arena when it comes to guidelines? Why we are majorly referring to those European and American guidelines. So I told my leaders, we do have a lot of cases that's about our practice, while the guidelines are more about the clinical studies, about how we translate studies into clinical practices. So these are two different things. I was also in the UK. I know their doctors could only see 5, 6 patients in the afternoon, while our doctors can see 50, 70, even 100 patients in a single afternoon. They told me that how they did this was to bring in 5 patients in a batch. And these 5 patients will explain their common problems, and then their assistants, their postgraduates will help deal with all the details. You know, the Mayo Clinics in the US, right? It's a very big clinic. It has actually not so many cases, but they spend so much money on their clinical studies. The cost on clinical studies may account for 20% of their overall expenditure. So that means in order to catch up, we have to improve our whole healthcare system significantly. It's not just simply replicating the Western approach. We are faced with great needs and demand from our leadership and from the society. So there is a lot of things to be done. And for the things we have discussed today, I think 2 things. One is lack of high quality evidence, and the second, lack of translation of high quality evidence. Because I have been a manager for 8 years in that hospital administration, and also a member of the Chinese People's Political Consultative Conference. So I can also offer some inputs from outside of this industry. You know, a lot of leaders do not pay attention to those professional issues because they are not professionals. They only have 2 simple questions. Can you heal the disease? And are the patients satisfied? So the first question is about the effectiveness. We may have guidelines, we may have the therapies in the guidelines, yet their actual effectiveness has not been demonstrated clinically. And there's another question with the equivalent efficacy. Which one is cheaper? Which one is more expensive? Which is better in terms of healthcare economics? And which therapy is more convenient? Which therapy has less adverse events? Which therapy is more acceptable by the patients? Those are all questions we should think about. So still back to the first question, how we can generate high quality evidence. That is the foundation of all the questions and problems we've been discussing. When we look at the guidelines and the standards, we know there are 2 things. One is the level of evidence and also the level of recommendation. If the RCT's sample size is very small, or the randomized and the double-blind has not met the requirement, we will not get a high level of evidence. Another issue is about the translation. If somehow through a series of clinical research, we may be able to get some therapies into the guidelines. Even with lower level of evidence, it can give our clinicians more confidence in using these therapies in clinical practice. And thirdly, from my experience of all these years, we have to pay much attention to evidence-based decision. If a medication can be reimbursed by the healthcare insurance, then that means a lot, because whether it can be reimbursed or not means a lot to the patients. So if it can be reimbursed and it has been included into the guidelines, that will give a full green light to this therapy. Previously, we may be talking a lot about evidence-based medicine. That's about evidence-based management. But as for the precise approach and solutions, I'd like to talk about my 3 thoughts. One is sharing. I agree very much to that. But it's not just about data sharing. It's also about biologic samples. Biological samples and the clinical data is basically linked to each other closely. Of course, we have great challenges on this. When I was working in this Shanghai hospital administration, we were promoting this program on data sharing. Everyone agreed that we have to promote data sharing, but then we found there were more issues with that because a lot of people tend to hide their data and their biological samples. They simply don't want to share all this work, their hard work, with someone else. We all say, yes, we want to share, but when you're asking them to share, their compliance is still quite low. So this is something that our industry, the academic community, even the government have to mutually promote. We have to raise our awareness. We have to invest, and we have to conduct organized research promoted by the government. And also, to make it international is also important. Today's meeting is also a very international meeting. Throughout all these years, almost 20 years, I have seen some progress, but I haven't seen any major breakthroughs. A lot of issues had been issues 20 years ago, but they remain as issues nowadays, and they are still being discussed today. So that means they are really big challenges. How we can take a big step forward, how we can engage some international experts right from the beginning of some programs. If we can do so, maybe we can make a bigger voice. If we can somehow publish a really high quality paper, that will help lay a sound foundation for publishing more high quality studies and writing more guidelines. 20 years ago, when Mr. Li was the head of China Bureau for Traditional Chinese Medicine, he emphasized that it is highly challenging to do clinical trials in TCM. We didn't have so much found. He also said if someday we can enjoy more support, more fund from the government, what kind of reward we can give to the country, what achievements we can make with this great support of funding. Now, a lot of TCM projects can get a lot of funding support, even dozens of millions of RMBs. Now, with all this funding, can we give our government more confidence? Can we give our general public more confidence? President Li talked about these TCM superior diseases, and I agree very much to his opinions.
I asked him, he told me previously we used the TCM elongating survival. This is no longer an advantage for us. There are very new drugs. Adding TCM elongating a couple of months of survival will no longer be our advantage. But for the non-responders, we can improve the ORR rate, right? That could be another point to cut through. So we need to differentiate what are the diseases we need to put on our agenda and prioritize these diseases. I do call for all stakeholders to come together to generate more evidence so that our field can move forward. Thank you so much for listening. Thank you, Professor Zheng, and also President Zheng, for your very wonderful speech and point of view. I would like to take this opportunity to share with you some of my points as well. I am practicing Western medicine for most cases. When I just took office in the traditional Chinese medicine hospital for 4 months, I'm coming from an oncology background, major in radiotherapy. In this hospital, I am the only one to propose that the way for cancer, the only way out for cancer is integrative medicine, especially triple negative breast cancer and biliary tract cancer. Orphanox, IO plus targeted therapy, 6 months FGL2, only 7% responders can be improved to 15 months or so. Currently, we are doing radiation therapy plus immunotherapy and a TKI for pancreatic cancer. Using one TS1 orally administered, the survival can be elongated. However, a lot of patients cannot tolerate this therapy. After coming to this hospital, we are actively conducting studies. I think only by combining TCM and radiotherapy can provide these patients with benefits. Immunotherapy plus TKI plus radiotherapy plus TCM can finally replace chemo. Like for pancreatic cancer or pancreatitis in Beijing, Shanghai, and other Guangzhou hospital, they have a formula prescription non-inferior to Western medicine like antibiotics, and we have shown very good efficacy as well. Based on this, I think integrative medicine is the only way out for some malignancies in particular to make breakthroughs. Especially, we are focusing on pancreatic cancer and biliary tract carcinoma. These are the king and queen of all cancers. If we can show good data in these two types of cancers, I think we can showcase the value of a TCM. Professor Gu is a researcher and a physician for pancreas. I do hope that for physicians in traditional Chinese medicine hospitals, you can provide with us more opportunities for investigator-initiated studies, IIT studies. In Western hospitals, oncology department has a 30 or 40 GCP program, but in the TCM hospital, we don't have this many opportunity to carry out the trials. With AI, deep learning, and machine learning, if we can collect biological samples, regardless of the mechanism, in combination with traditional Chinese medicine and Western medicine, we can find the targets and to elaborate on the mechanism behind the TCM. Mechanism-wise, we will have more weapons in our arsenal, from cells to organoid to animal models. I do believe for herbal medicine and the TCM medicine, if we can make it like a formula of preparations, in combination with the radio chemotherapy or immunotherapy plus radiation therapy, for malignancies, we're in the era of immunotherapy plus. I'm very confident to tell you, with the highly malignant tumors, we can show the value of integrative medicine. Thank you for listening. That's my add-on information. It's a rewarding meeting for me. I learned a lot. Thank you for the opportunity. Last but not least, let's welcome Professor Franco, our chair, to give us the closing remarks.
Well, thank you so much for impressive debate. Took lots of notes. A huge thank to all the speakers and the panelists for all the engaging conversation. I would like to highlight a couple of cross important topics that I saw throughout the panels. The first panel had to do with, oops, this is the wrong one. The evidence frameworks, right? So for the evidence frameworks, there was many aspects that I didn't know, I must confess, about the research that was done into thinking about this evidence framework. Particularly, I was surprised about this whole evidence approach, looking at different sources of evidence. We always talk about real-world evidence, but in this case, we're talking about investigating a little bit more about the theories and the frameworks. And I would say that the theory of TCM was a recurring theme throughout the different panels. And having a good idea of what are the theoretical frameworks is particularly important. It was mentioned from beginning to end, even the last remarks by the last panel to understand the panel chair. then we spoke, when we talk about the frameworks, we talk about transparency, reporting, creating good standards, basically a little bit of what we said at the beginning about the overall challenges in every research, not only in TCM, and problems that we've seen for, as other panelist members said, for many, many years. The same thing has been said about blinding and the difficulties in the challenges from the methods of running trials for TCM. I think it's important not only to get comments, but also key questions that I heard during the first panel sessions. And I remember one question from Professor Tang that says, I don't have the exact text of what he said, but he said, "Who are we trying to convince?" And it was something that caught my attention because I was a little bit by surprise, and that spoke to a little bit about how we think about evidence and some of the words that we use in the context of evidence-based medicine. Sometimes evidence-based medicine is used in the context of TCM to talk about validation, or sometimes internationalization, and he mentioned the word convince, which I thought that it was super interesting in saying what are the expectations from the evidence frameworks in general. From my perspective, as in my expertise in evidence-based medicine, I understand that evidence-based medicine is not trying to convince anyone, it's not trying to do anything international, and it's not trying to validate any treatment. It's trying to see if something works or not. And sometimes it may work, sometimes it doesn't work. But if there's an initial doubt and a curiosity as to understanding whether a treatment may be effective or not. And that is a little bit different in some of the discussions that we've heard, where there's a lot of emphasis in trying to get validation or not. And I'm not saying that TCM, please, I want to be fully clear. I'm not trying to say that we need to see if TCM works or not. I'm just trying to say from the evidence-based medicine framework, that is not a validation or internationalization framework. It's a curious approach to understanding treatments and clinical approaches, which I will go back to that topic because there was another question that was done in the other panel. But another thing about frameworks that I found, I will move to the second panel where there was discussed about integration and the tensions between, and I thought it was super interesting. There was a slide by one of the professors that highlighted the different levels of integration from theory into evaluation, and that most commonly we see integration from the treatment perspective, and that the theory was very difficult to integrate. Again, we hear the topic about theory that we heard in the first panel. And I was thinking, well, again, we're coming back to the theory. It's very difficult to integrate the theories and the diagnostic frameworks. We try to integrate treatments, and then we heard very interesting examples about things that we considered in Western medicine as low-hanging fruits, things that everyone agrees. Everyone wants to stop using antibiotics, right? And they use the potential use of traditional medicine as a tool to save antibiotic use is very convincing. And it's a very good selling point for Western medicine to find different alternatives to combat things that we cannot fully solve. And I think that if you're thinking strategically, because there was some thought about what are the priorities, right? Because it could be done research on everything. What are the priorities for research? It would be, what are the, especially if you want TCM to be captured outside of China, what are the priorities in which TCM can provide something that Western medicine cannot? And that was a very convincing example from one of the speakers. And then there was one of the speakers spoke about TCM as a complex intervention. And again, I'm fascinated by the topic of TCM as a complex intervention. And and the need for different types of evidence. Economic evidence, I would add evidence about acceptability that was also presented by some researchers, qualitative evidence to understand what people think about TCM, especially outside of China. And then Professor Liu, which is not here, he said also another important question. He didn't say it as a question, but I would change it as a question. He said EBM as a common language in integration. And my question is EBM a common language of integration, or is it making it difficult for international medicine to be integrated? Because we're trying to force all the types of medicine into the EBM framework that is being criticized as being reductive somehow. So is it a common language or is it not a common language? And building up on that, there was also a discussion of say, okay, if EBM is all about tools, right? Grade, synthesis, randomized controlled trials, perhaps we need to change the tools. And there was a proposal to say, well, grade doesn't work very well, we should get new tools. But the question is, if the tools for TCM are different, how would that be perceived by the international medical community, having a different types of evaluation standard? That is another question that I had. And then we get into the last panel that it was about, I want to say the title right, implementing TCM interventions in clinical settings. And I was, again, very engaging and interesting topics, and the presentation, all the presentations were excellent, but especially I found the examples with the influenza and COVID-19 and the different types of why is it effective in one place and one effective in another place. And at some point they started talking about beyond the culinary differences in China. It was also mentioned the different climate aspect, whether it was dry or wet or so on. And I was thinking again, this was presented very early in the first session as part of one of the theories, right? So again, we're coming to the topic of theories and how important is always going back to the theory to understand differences. And for me to see that going back to theory, well, perhaps it's different because it was affecting it was tested in a different region that had different geographic and climate properties. It might have been some of the explanation. It was particularly persuasive when we're thinking about evaluative frameworks. And it was also, I think, one of the few examples, if not the only example, that it was shown about trials of TCM outside of China, outside of China that were not about acupuncture, right? Because we know that there's a lot of acupuncture about China, but TCM, herbal medicine research outside of China, and that was hopeful in the sense of a good narrative as to how that was perceived somewhere else. That, well, if it's effective, then we perhaps need to use it, right? And that comes to the point of the importance of engaging patients in research. Very early in the process, if you engage patients at the end when you have the results, it's not the same if you engage patients from the beginning. So if you're doing research, especially outside of China, it would be very good to engage patients from the beginning because it will be key in disseminating your results and engaging with them. And then there was, I don't want to overlook the system level aspects, and it was a mention about, I really like the idea, the proposal saying, well, we're talking a lot about data sharing, but are we sharing the data about how well we're adhering to our practices, and the whole debate as to the different schools of treatment within China, and the issues about reimbursement. And when I heard evidence-based management, I also thought that, well, how does the evidence-based medicine approach in the evaluation of therapies fits into the larger quality of care evaluation in healthcare systems? That is in hospital management, standardization of procedure, not only the guidelines, but how the doctors are trained within the hospital, and the fidelity of the complex interventions at the point of care. And And usually a lot of the discussions that we saw was about the trial yes, trial no, real world evidence yes, real world evidence no. But to hear about what actually happens at the hospital and whether that can be evaluated, it was very refreshing as to complement the whole idea from the theory, the evidence, and the implementation. That is a very quick summary, and I'm probably missing 80% of what it was said because I have lots of notes, but my purpose here is not to do a summary of everything. I like evidence synthesis, but not so much as to synthesize the whole panel because everyone did a wonderful job in explaining their ideas. I do want to on the behalf of the BMJ VM and the BMJ Group, thank to Beijing University of Chinese Medicine for a long-lasting partnership and Yangtze River Pharmaceutical for the support. We'll be in touch with the partners for this project to follow up on the outputs that was mentioned very early in the presentations. There will be a microsite and that will have the meeting report, the key discussions for today to promote all of the main ideas that we discuss and more importantly, extend these insights into general medical practices. We will also have a commitment to have some editorial material in our journal that reflect the discussions today. Building on this event, BMJ-BM is keen to engage with high-quality Chinese articles, as one of our associate editors, Dr. Duan, mentioned that we have already been doing that, not only focus on the development of integrative medicine, but also aiming to improve the clinical outcomes in broader context outside of China. Great thanks to all of your contributions today, and have a good evening, and nice to see you again. Thank you so much.